So it's already started there. Yeah.
Okay.
The person you are.
A very good evening, everyone. Hello, my dear doctors. A very good evening, everyone. A warm welcome to DocTutorials. So this is Dr. Azam here. Thank you, Abhijit. Thank you, Amelia. So this is Dr. Azam here, Faculty of Anatomy at DocTutorials platform. And now we are actually starting with a discussion of NEET PG Elite test series. Actually, if you are following up with our platform, yes, we have started with the NEET PG Elite test series of all the subjects, and already the schedule is given to you. And apart from that, anatomy, we have completed like 3 test series. 3 tests actually we have completed. That was on 20th, then 22nd and 24th. And after that, yeah, after completing the test, as we have promised, like every faculty will be discussing that one. And yes, of course, after anatomy, now tomorrow, like biochemistry elite test will be streamed live on the app. So I request all of you to please give the test, and following that discussion will be done with the faculty. All the high yield topics as well as high yield concepts will be completed in that one. Okay. Yes, Abhijit, welcome. Very good evening, Sama. Ahmed, very good evening. Oh, Dhawan sir, thank you, Dhawan sir. Thank you, Dhawan sir. Rafiq Rahman, hello. Good evening, Hanan. Yes. Okay. Good evening to everyone. So a warm welcome to all of you guys. Now, if you all are ready, then let's get started with the discussion. So if you people have attended the test, I hope you all have seen the questions, the kind of questions. I have tried to give most of the clinical questions of anatomy and integrate with other subjects also. And apart from that, certain image based questions, all the high yield concepts to be touched. So those I have given there. Yeah. Good evening, Ahmed. Yeah, fine. So before any further ado, let's get started, guys, now. So you can see the question number 1 here. So the very first question, it says that a 43-year-old woman came with a large abscess in the middle of the right posterior triangle of the neck. The posterior triangle of the neck. The physician incised and drained the abscess. 5 days later, the patient noticed that she could not extend her hand right above her head to brush her hair. Which of the following are the signs and symptoms of the additional harm? So whatever this additional harm she is getting, she is unable to raise the hand, yes, to brush her hair. So what is the problem? Let us see that one, right? Okay. So first of all, guys, there was an abscess in the posterior triangle. So in this diagram, you are able to see the posterior triangle of the neck, which is bounded by the sternocleidomastoid muscle here. And this one here will be the trapezius muscle here, guys. And below there will be clavicle. So sternocleidomastoid, the trapezius and the clavicle, between them you are able to see that there is a posterior triangle. Now in that posterior triangle, the question says that there was an abscess and that was drained, but later on she developed the complication of like the problem with the raising in her hand. So in that you actually have to know like what is the content of the posterior triangle. If you observe this posterior triangle very carefully, in the middle of the posterior triangle you'll be seeing the accessory nerve, 11th cranial nerve passing from here, which is like the content of that one, guys. And it is located on this muscle, or it is placed on that muscle. This is nothing but the levator scapulae muscle. This question has been asked a lot of times in the exams, in the NEET PG exam, especially regarding the triangle of neck. So there is a levator scapulae muscle, and overlapping that you are able to see a nerve there, and that is your accessory nerve. And during draining that abscess, most of the time what will happen, that nerve will be injured. If there is an injury to that particular nerve, then what is going to happen? Muscle supplied by the nerve will be paralyzed. And I hope all of you know that the 11th cranial nerve, the 11th nerve, your accessory nerve, is the one which will be supplying to 2 important muscles. One is the sternocleidomastoid muscle, and another one will be the trapezius muscle. Sternocleidomastoid muscle and trapezius muscle. And trapezius muscle is the one which will be actually helping you in overhead abduction of the arm. And that we have actually studied in the upper limb topic. If you all remember, in the upper limb topic, I taught you about the abduction of arm 0 to 15 degrees, 15 to 90 degrees, and above 90 degrees overhead. So, for brushing the hair, overhead abduction of arm is required. That means it is done by trapezius muscle. And now the trapezius muscle is actually paralyzed. Understanding? That is the story behind this one. So it's like integration between head and neck topic as well as your upper limb topic. You should have the knowledge of everything. Then you'll be able to answer this one, guys. Okay. So which of the following? What is the following problem here, sir? Damage to scalenus medius muscle? No, that is not the answer. Injury to suprascapular nerve? No. Suprascapular nerve will be supplied to supraspinatus and infraspinatus muscle. Whereas cut to the spinal part of the accessory nerve. Yes, spinal accessory nerve is injured here. Spread of infection to shoulder joint, it has nothing to do with the shoulder joint over there, guys. Understanding? So that's the clarity about this concept. Hope it is very, very much clear. Yeah, I'm good. Thank you, Mystic Medico. Very good, Rahman. Very good, Alia Khan. I hope you have understood that one right now, hai na? Yes, thank you, Jahangir. Now moving on to the second question right now, guys. Evaluation of an infant reveals hypocalcemia due to lack of parathyroid hormone. Okay, hypocalcemia due to lack of parathyroid hormone, PTH. On X-ray, the thymic shadow is absent. Thymic shadow, thymus, is absent. Which of the following embryonic structures is involved? Okay. So, I hope you people have learned about the development of pharyngeal arches, pharyngeal pouches, and pharyngeal clefts. Ectoderm is the one which is going to form your pharyngeal cleft. Okay, and the endoderm will be actually forming the pharyngeal pouches. So pouches are actually formed from the endoderm, guys. Now in this you are able to appreciate here the pouch number 1 and then the pouch number 2, 3 and then 4. Out of that, I hope all of you remember the pouch number 3, the third pouch. Third pouch is going to form thymus. In most of my classes, I advise the students remember with the rhyming word, third thymus. So third pouch is going to form what's a thymus. Along with the thymus, it is also going to form parathyroid gland, and along with the thymus, it is going to form inferior parathyroid gland. And the fourth pouch is the one which will give rise to superior parathyroid gland. Now, if you just observe here, what is actually explained in the question is that on X-ray, you're not able to see the thymic shadow. That means you're not able to see the thymus. And then parathyroid hormone, due to decreased parathyroid hormone, there is hypocalcemia. Okay, yes, of course, very good, absolutely correct, Dr. Pragya. Yes, it is actually speaking about the DiGeorge syndrome. Yeah. So that is actually the problem related to which pouch. Embryologically, developmentally, it is a problem related to like which pouch here, sir. Is it the third pharyngeal cleft? No, the problem is not at all with respect to cleft. It is with respect to pouch. And when there is no thymus, out of the third and fourth, the better option will be the third pouch, guys. So third pharyngeal pouch, absolutely correct. Okay. Next one, moving on to the next question now. Newborn baby is noted to have a cleft unilateral upper lip. Okay, now left unilateral cleft upper lip, left side. There are no abnormalities of the baby's palate. Palate is perfect, but there is only problem with the cleft unilateral upper lip. Which of the following developmental defects accounts for this occurrence? Like, what is the defect now? First, let me tell you like how is the upper lip formed, sir. Observe this diagram over here. Now in this diagram, you are able to observe here, this is the maxillary process or the maxillary prominence. Okay. And that maxillary prominence is going to fuse with the medial nasal process. That is something important where most of the students will be getting confused. So maxillary process is going to fuse with the medial nasal process, and that is going to form your upper lip. Now suppose if this maxillary process is not able to fuse, there is non-fusion of the maxillary process with the medial nasal process, then it will be obviously what side? It will be a cleft lip, and that too it will be unilateral. If both the maxillary process, are not able to fuse with the medial nasal process, then it will lead to bilateral cleft lip, which is also known as the hair lip, resembling like that of the hair. So now you can clearly see here the upper lip is actually formed by the fusion of maxillary process of both the sides with the medial nasal process. Now, if any one is not fused, then what is going to happen, guys? It will lead to unilateral cleft lip, and that is what is given. So what should be the answer? There is non-fusion of maxillary process with the medial nasal process. So if you observe the second option here, failure of left maxillary prominence to unite with the left medial nasal prominence, that is absolutely correct option, guys. I hope it is crystal clear there, guys. Hello Ankit, welcome to the session here. I hope you are able to recall the concepts here, guys. Yes. Now moving on to the next thing. A person has been brought in casualty with the history of road accident. And he lost consciousness transiently and then gained consciousness, but then again became unconscious. Oh my god. So it is like, transient, gaining consciousness, again losing the consciousness. Again he's going to become unconscious. Most likely he's having the brain hemorrhage of, yes, intracerebral, subarachnoid, subdural or extradural. I hope the moment you read that, you'll be easily able to understand that, guys. The moment you read that thing, you'll be able to understand there is like, transient, gaining consciousness and, again becoming unconscious. And that is a characteristic feature of extradural hemorrhage. Okay, now, extradural or epidural hemorrhage, guys. Okay, and you all know very well the extradural hemorrhage will occur due to rupture of what? It is due to the rupture of middle meningeal artery. Absolutely correct saying. Absolutely, Dr. Ravi. Yes, very good, Sneha Patel. Everyone, absolutely correct. Very good, Neha. Yes, very good, Garima. Yes. Between the lucid intervals, there will be, yes. It will be due to which artery, guys? Middle meningeal artery. Achha, by the way, little bit extending forward there. Epidural hemorrhage. Yes, it is due to middle meningeal artery rupture. Then can anyone tell me it is going to pass through which foramen, which cranial foramen? The middle meningeal artery. Let us just, correlate the things here. It is due to rupture of middle meningeal artery, and a middle meningeal artery is going to pass through which cranial foramen? Alia Khan, yeah, you are absolutely correct there. Middle meningeal artery is going to pass inside the Pterion. It is just present, beneath the Pterion there. Fine, very good. But which foramen? I mean, I'm asking there. Absolutely correct. Middle meningeal artery is going to pass through foramen spinosum. So in this way, in this discussion, I'm trying to cover like everything possible, guys. Is it okay? So we have learned this in head and neck topic. If you people have watched my videos on DocTutorial app, you have seen one of the topic that, the cranial foramens. And in cranial foramens, I've explained it very clearly. Foramen spinosum, there will be two structures passing, nervus spinosus and middle meningeal artery. And if this artery is ruptured, leading to epidural hemorrhage. And now in this LI test series, I'm trying to giving you all the clinical questions, how to correlate with that one. Yes, as Dr. Garima said, there will be gaining and, losing of consciousness with lucid intervals. Yes, that is a feature of epidural hemorrhage. And I have covered the anatomy part of that in detail, guys. I hope you're getting it, guys. Thank you. Yes. Absolutely. I'm really happy the way people are actually interacting here. Yes, I want this thing right now in my session. Yes, sir. Keep on doing like that. And don't worry whether if you're right or wrong, no one is going to judge you here. We have come here to learn something. And I strongly believe that when you're learning something now, you are bound to make mistakes. And you are allowed to make mistakes. Make as many mistakes during the discussion here, but don't repeat the same thing in the exam. So for that reason, I'm telling you, answer here. No one is going to judge whether if it is right or wrong. If it is wrong, I'm here to correct you guys. Okay. So with that positive note, let's move ahead. A patient with a crocodile tear syndrome has spontaneous lacrimation during eating. Oh my God. Spontaneous lacrimation. Okay, lacrimation, crying, tears are going off during eating. Normally during eating, someone will expect the salivary glands to secrete. Okay, now there should be salivation during eating, but during eating, what is happening here? There is actually lacrimation occurring, guys. Due to misdirection of regenerating autonomic nerve fibers, which of the following nerve has been injured here? Which of the following nerve has been injured here, guys? Okay. So for that, little bit, I'll tell you about the seventh cranial nerve, sir. The cranial nerve number 7. Seventh nerve. That is your facial nerve, guys. Okay. So someone is answering as A, someone is answering B there. Okay. Rafiqur Rahman. Okay, Ankit, Sneha, Pritiraj. I have seen your answers. I'll get back to you. Okay. Now, first of all, I hope all of you know that the seventh nerve, the nucleus of seventh nerve will be located inside the pons. But there is one interesting thing inside the pons. There will be nucleus of the sixth nerve there, sixth nerve nucleus, abducens nucleus, but the seventh nerve nucleus is more anteriorly present. And what is going to happen? Yes, it is going to take a turn and then come out, exit out. And then seventh nerve is going to go laterally, then take a turn backwards and then downwards. Laterally, it is going laterally, then taking a turn and going backwards, it is going back, and then it is going downwards. And after that, I hope you all know it is going to come out of that foramen, that is stylomastoid foramen. And after coming out of the stylomastoid foramen, it is going to pierce the parotid gland and divide into that 5 terminal branches. 5 terminal branches, your favorite one, which you normally learn by keeping a hand like this here. And it is going to pierce which gland there, guys? It is going to pierce the parotid gland. Fine. Sure. Okay. So in this, I have just given you like overview the entire structure, like how the facial nerve is normally traveling. Okay, so first it's like a 3D thing, sir. So I'm trying to make the diagram like more of a 3D, if you are able to understand on my screen here. So it's first going laterally, then going backwards, then it is going downwards. Okay. Now there will be actually a ganglion here. There will be actually a ganglion here. Yes, that is nothing but the geniculate ganglion. And yes, there itself, right at the turning part, that is known as genu, external genu. So near the genu, the seventh nerve, our facial nerve, will actually give a branch, and that branch will be the great petrosal nerve. Greater petrosal nerve. Greater petrosal nerve, guys. Okay. So greater petrosal nerve is a branch of your seventh nerve. Very good. We have learned that thing. Then apart from that, I hope you all know that there will be a middle ear cavity over here. Middle ear cavity over here. Now I'm not going into the details of all the relations and everything over there. Right in the front of that, I hope you have seen that there will be internal carotid artery. Internal carotid artery, and around the internal carotid artery there will be sympathetic plexus. You all know very well, whenever the sympathetic plexus has to supply to anything, they'll be actually going along with the blood vessel. So internal carotid artery, around that will be having the sympathetic plexus. Then from this sympathetic plexus, what is going to happen, guys? There will be a nerve coming from here. That will be the deep petrosal nerve. That will be deep petrosal nerve. Remember, it's not lesser, it is actually deep petrosal nerve. So this greater petrosal nerve and the deep petrosal nerve, now what is going to happen? They are actually going to go through the canal, and that canal, that they're actually both the nerves together, they are referred to as your Vidian's nerve, the nerve to pterygoid canal, or the Vidian's nerve, so Vidian's nerve. And now what is going to happen, guys? This greater petrosal nerve, the greater petrosal nerve will actually go and end in a ganglion, and that is nothing but your pterygopalatine ganglion. And that pterygopalatine ganglion, from there another nerve is going to begin, and that will go and supply to the lacrimal gland. I hope all of you have learned this very, very clearly, crystal clearly. Yes, in the regular classes, or in our app there, I have explained the entire all the cranial nerves one by one, all the cranial nerves we have learned, third, fourth, fifth, sixth and all in detail. And I told you at that time, this is like a beautiful concept, very important concept here. So I repeat again, seventh nerve will give a branch, that is your greater petrosal nerve. Let me just repeat that again, guys. The seventh nerve will give a branch, that is greater petrosal nerve. And then that is joining along with the deep petrosal nerve coming from sympathetic plexus around the internal carotid artery. And that is lying right in front of the middle ear cavity. And both these nerves are going to form the Vidian's nerve. And that is also a very important question for your NEET PG, has been asked many times in your exams. And that great petrosal nerve, I'm not concerned about the deep petrosal nerve right now. I'm not going in detail about that one. I'm concerned about the greater petrosal nerve that is going and ending in a ganglion. That ganglion is pterygopalatine ganglion. And yes, you all know about the functional nerve and topographical nerve concept. If that nerve is going to end in the ganglion, it's going to stop there. You'll not be able to see that after the ganglion. There is a functional nerve. You'll not be able to see that nerve after the ganglion. So after the ganglion, there'll be another nerve. That nerve will go and supply towards a lacrimal gland. Okay. Now what is happening here? what is happening here? If there is an injury to this nerve, if there is an injury to this nerve before this geniculate ganglion, if there is an injury to this nerve before the geniculate ganglion, then what is going to happen when it is going to regenerate? Normally, the fibers which are going to regenerate and go to the salivary gland, sir. Thus, the fibers which has to go to the salivary gland, even those fibers will be actually going through the, when they are trying to regenerate now, those fibers will also go through the greater petrosal nerve and will go and supply to the lacrimal gland. Normally, while regenerating, those nerve fibers should go from here, and then there is one more branch of the seventh nerve that is actually known as the very famous one, the chorda tympani nerve. And that chorda tympani nerve will be finally going and supplying. Finally, it will supplying. So I'm not going in on all the detail. Finally, that chorda tympani branch is supplying to submandibular and sublingual. So I think someone was actually answering there. Chorda tympani. No. Chorda tympani branch is supplying to which gland? Salivary gland. Chorda tympani branch is supplying to salivary gland. Whereas greater petrosal nerve is actually going to supply to your lacrimal gland there. अब यार इन दोनों का क्या connection है? What is the problem between them? The problem is that if there is an injury to the facial nerve before this geniculate ganglion, if it is injured here, then while regenerating, the fibers which has to actually go to the salivary gland from here, instead of that, some of the fibers are also going towards the lacrimal gland via the greater petrosal nerve. Okay, so when the person is trying to eat, normally what should happen, your salivary glands should actually secrete, but because the same fibers are also going to the lacrimal gland, so whenever the person is trying to eat the food, what is going to happen? The person will be crying there, and that is known as crocodile tear syndrome. Wow, what a beautiful concept. Are you understanding? So whenever person is trying to eat, जब भी बंदा खाना खाता है, whenever the person is trying to eat there, normally there should be secretion from the salivary gland. Only those fibers should be stimulated. But during regeneration, because the fibers are also going to the lacrimal gland, they will also be stimulated. And whenever he's trying to eat, he'll be crying there. Whenever he's trying to eat, he'll be crying there. And that syndrome is known as what, sir? Crocodile tear syndrome. Crocodile tear syndrome. I hope it is very clear. Very, very clear, guys. Yes, so I think almost like I told you the important concept in the seventh cranial nerve. Now read the question again along with me, guys. A patient with crocodile tear syndrome has spontaneous lacrimation during eating due to misdirection of regenerating autonomic nerve fibers. Wow. So each and every word is given very clearly there, whatever I explained you. Understanding? I think now you're able to understand the question more clearly. So which of the following nerve has been injured? Yes, the facial nerve proximal to geniculate ganglion, chorda tympani in the infratemporal fossa, or facial nerve at stylomastoid foramen, or the lacrimal nerve directly. No. It's actually the facial nerve proximal to geniculate ganglion. This is the thing, sir. Okay, the facial nerve proximal to geniculate ganglion have been injured, guys. Facial nerve has been injured there. Is it okay? Fine here. Perfect. I hope it is like crystal clear concept now. Okay. Now after this, my dear friends, after understanding this concept here, let us go ahead right now. Yes. अब आगे बढ़ते हैं. Let's go ahead right now, guys. Yes. Very good, Abhijit. Very good, Abhijit. Acha, one more thing I want you to remember is that facial nerve itself is the one is giving a branch to one of the muscle in the middle ear. Yes, that is your stapedius muscle, guys. Stapedius muscle. Okay, so in the middle ear, stapedius muscle. So yeah, it is also getting a branch from the facial nerve. That nerve itself is known as nerve to stapedius. Keep that also in mind, and that is important for your another reflex, that is stapedial reflex. Stapedial reflex, guys. Okay, perfect. I'm really happy. Yes, very good, Dr. Alia. Yes. चलो आगे बढ़ेंगे. Shall we go ahead now? A 68-year-old woman presents in the emergency room with dizziness and nystagmus. Examination reveals a loss of pain and temperature sensation. Pain and temperature is lost over right side of the face, and left side of the body. Loss of pain and temperature on the right side of the face, whereas pain and temperature will be lost on the opposite side of the body. Fine. Okay, so pain and temperature, I hope you all remember, from the body will be carried by the spinothalamic tract, and spinothalamic tract is actually going to cross in the spinal cord itself. Okay, so it means that if there is a left side of the body, the pain and temperature is lost. Yes, if there is a pain in the left side, there is definitely, yes, there is some problem towards the right side. Let's see, because already the tract is crossing towards the right side in the spinal cord itself. The patient exhibits ataxia, and intentional tremors on the right side, in the upper and the lower extremities. Okay, fine. And then demonstrates papillary constriction and the drooping of the eyelid on the right. Fine. Yes, absolutely correct. Finally, the right side of her face is drier than the left side. The right side of the face is drier than the left side. Which of the following artery block would explain the patient's condition? See, one thing is very clear when you see the conditions like, ataxia. One thing is very clear, guys. When you see these conditions like ataxia, the dizziness, nystagmus, and all those things, yes, of course, it is speaking about the medullary syndromes. Okay, so all these things will be seen in the medullary syndrome, guys. And here, yes, when it is medullary syndrome, obviously, yes, the artery that is involved there will be the cerebellar artery, inferior cerebellar artery. And now, is it first of all, you have to decide ki anterior or posterior. Okay, if it is the yes, if it is actually the lateral. Yeah. Ankit remembers that mnemonic that I told in the class. Yes, L for large spinal thalamic tract. Yes, very good. So if it is the lateral medullary syndrome there, yes, of course, it will be the inferior cerebellar artery involved. And yes, if it is towards this right side of the face and all those things, yes, of course, the right posterior inferior cerebellar artery will be involved in this one, guys. So this is actually explaining about the medullary syndrome, and in this, the right side, the posterior inferior cerebellar artery will be involved. Yes, I've explained about all these syndromes in detail, about the midbrain syndromes, all that, Benedict syndrome, Weber syndrome, and even the Pontine syndromes also, as well as lateral and medial medullary syndrome. In detail, we have worked out on this one here in the videos, guys. You can always check in the DocTutorials app there. A middle-aged woman complained that her right hand tremors when she attempts to insert a thread in the eye of seeing in the needle. Okay, right hand tremors when she is trying to insert the thread in the needle, and her body sways towards the right side while walking. Okay, fine. On physical examination, the physician found that there is flaccidity of the limb muscles on the right side. When she was asked to touch the tip of her nose with her right index finger, the finger tended to overshoot the target. Okay, fine. So which part of the brain is mostly affected? Again the same thing, my dear friends. You can clearly see there, it's mostly about the movements. Okay, so therefore here also the cerebellum part of this woman has been affected here, guys. So whatever is said in the whatever is said actually in the question there, it's mostly relating with the cerebellum, guys. A patient recovering from the traumatic injury to the face now finds himself unable to chew his food. Chewing the food, muscles of mastication will be involved. Okay. So when he's telling about unable to chew the food, obviously muscles of mastication, there should be some problem. On physical examination, his jaw deviates to the right side. The nerve that has been injured in this patient exits the skull through which of the following foramina? So we all know very well, muscles of mastication, there are totally like 4 muscles of mastication. You'll be having masseter, temporalis, lateral pterygoid, and medial pterygoid. And all the muscles of mastication will be supplied by mandibular nerve, that is your 5-3, the third branch of trigeminal. Okay, 5-1, 5-2, 5-3, 5-3. So we all know very well, 5-3 mandibular nerve will be passing through foramen ovale. I hope you know the mnemonic. What are the nerve passing through foramen ovale, guys? Male. So please remember this. 3 foramens here, the foramen ros, rotundum, okay, and then the ovale and the spinosum. There will be rotundum, ovale, and spinosum, hot favorite of the examiner, guys. And what are the structures passing through ovale? Ovale, there will be male. Let us revise. M stands for the mandibular nerve, A for accessory meningeal artery, L for lesser petrosal nerve, and E stands for the emissary veins. Absolutely correct there, guys. Very good. Artery lying deep to the marked area in the given picture is a branch of which of the following? So someone was answering this one. Someone was telling about this one. I hope you are able to identify this region. This region is actually your pterion. Now, if this is the pterion, what is the artery lying deep to that one? That is your middle meningeal artery. To be more specific, it will be the anterior division of the middle meningeal artery, sir. So Pterion, that area which is marked there will be a H-shaped suture, and then below the Pterion or beneath the Pterion, the artery present there will be middle meningeal artery, and that is anterior division of the middle meningeal artery. Fine. But in the question, they're not asking like which artery is present beneath that one. It is not asking which artery is present there beneath that one. It's asking in the question, it is a branch of which one. So remember, middle meningeal artery is a branch of your maxillary artery. Now, please try to recall, maxillary artery will be totally giving like 16 branches, and it is divided into 3 parts, guys. The maxillary artery is divided into 3 parts by lateral pterygoid muscle. So lateral pterygoid muscle divides the maxillary into first part, second part, and third part. Out of that, the first part, every medical student, I hope you remember those mnemonics. The first part we remember as MAIDA, M-A-I-D-A, 5 branches. The first part will give like 5 branches, and out of that, M stands for what, sir? Middle meningeal artery. So remember, middle meningeal artery is a branch of what, guys? Maxillary artery. Which part of the maxillary artery? The first part of the maxillary artery, guys. First part of the maxillary artery. Fine. Chalo, badhiya. So you are able to see one beautiful picture here. Yes, it is on the inner aspect of the Pterion. So Pterion we are looking from inside, and when you see from inside, that is the anterior division of middle meningeal artery. There is anterior division of middle meningeal artery, guys. Next one. A 46-year-old man complains of dryness of mouth. On examination, he lacks salivary secretion from the submandibular gland. So submandibular gland, there is a lack of salivary secretion. This indicates a lesion of which of the following nervous structure? I hope I told you the entire course of the 7th nerve just now very clearly, guys. If there is a lack of secretion from submandibular gland, definitely which branch? Chorda tympani branch of your 7th nerve, guys. So greater petrosal, no. It is supplying to lacrimal gland. Yes, of course, that should be like chorda tympani branch in the middle ear cavity. Remaining no, guys. Yes, just now we have seen it very crystal clearly. See, that is the advantage of learning conceptually. I always tell you people that, learn anatomy like very conceptually. Like many of the people are actually having a wrong concept in their mind. Okay, anatomy is like, very boring subject, or, only for mugging or cramming. No, it's not about mugging or cramming. If you understand properly, it's like very, very conceptual. So just now we have seen the concept of 7th nerve clearly. See how many questions we can easily solve from that one. Similarly, just imagine if you learn all the cranial nerves properly. You are done, guys. You will be able to solve like many questions. A patient presented with the pustule over the dorsum of the nose, okay, and upper lip, which is the most direct route of spread of this infection to cavernous sinus. Oh. I hope you will have learned about the veins of the face. Did you all learn about the veins of the face, guys? So when you learn about the veins of the face, yes, my dear friends, you'll come across that there will be a facial vein here. There will be a facial vein here. Okay. So suppose if this is the facial vein here, then now the problem here is that there is some upper lip and the dorsum of the nose, there is some, there is a formation of pustule or something like that. They are trying to tell you that there is some infection over there. Now this infection will be traveling all the way to the cavernous sinus. How? There are actually 2 routes. I'll tell you one route here. From the facial vein, first of all, it can be traveling via the deep facial vein. And then from the deep facial vein, it will be going to the pterygoid plexus over here. Okay. And then from the pterygoid plexus via the emissary veins, it will be finally going to the cavernous sinus. This is like one route, sir, which we actually study very commonly during our first year MBBS days. So during our first year MBBS days, when you're writing your prof exams, okay, now at that time you will be actually studying this route. So if there is any infection in this region here, which is also referred to as the dangerous area of the face. So dangerous area of the face, There'll be some infection in the upper limb here and the dorsum of the nose, and from there the infection will be carried to the facial vein, and from there to the deep facial vein, then the pterygoid plexus and emissary veins will be carried to the cavernous sinus, which is more dangerous. Why? Because the infection which is present outside here, it is actually going inside the cranium. But in exam here, they are actually not asking you about this route here, sir. Okay. Most of the time, whatever options are given here, those options are actually not giving this one here, guys. Okay. Now one more route that is present here is that, okay, yes, from here, from the facial vein, that can be carried to the angular vein near the medial angle of the eye, angular vein, and from the angular vein, the ophthalmic veins. You know, from the orbit, the facial vein is going to drain via which veins here, sir? That is your superior and inferior ophthalmic veins, guys. So that is like another route, the angular vein, and from there the ophthalmic veins are going to carry that infection, guys. Okay. So yes, of course, from out of these two things, the directly it is going to carry via the angular vein to ophthalmic vein to the cavernous sinus. Understanding? So angular vein to the ophthalmic vein, and ophthalmic vein to the cavernous sinus. Wow. So normally during our regular classes, we'll study in anatomy only the veins of face, veins of face. But this is the clinical application of that. Yes. welcome Saichand. Yes, Saichand. I'm in Hyderabad here now. Hanji. So that is the reason why I'm telling you guys, that's the advantage of attending all this elite test series that has been specially made for you people at DocTutorials platform here. Okay. So I hope you're observing there. Whatever normal concepts we study normally in anatomy in our regular classes, like veins of face and all these things here. And now, see, you can see the questions which are framed for you people in a clinical manner. Understanding? So try to attend all the elite test series. Like tomorrow we also have a biochemistry test. Starting after anatomy, we are having like biochemistry. Tomorrow it will go live from 7 p.m. onwards. You can attend that one, guys. Now, a child with the chronic suppurative otitis media develops recurrent meningitis. The spread of infection to CNS most probably occurred through which fissure? Yes, it is actually the Hurdle's fissures. This will be actually a question which is mostly related from your anatomy to ENT. I hope you will have learned. In the petrous part of temporal bone, you'll be having this fissure, Hurdle's fissure. In the petrous part of the temporal bone, there'll be fissure here. And that fissure normally has to close during intrauterine life. Somewhere around by 24th week or 5th week of gestation, it'll be clear. It'll be actually closed. But if it retains even after birth also, then this kind of things will occur. Like the infections are going to move through that one, guys. Okay, so otitis media, suppurative otitis media, and from there what is going to happen, the infection will go to CNS via this fissure. Normally it has to close during the intrauterine life. Is it okay? Yes. Which of the following pharyngeal arch give rise to the development of branchial fistula extending from base of the tongue to the anterior border of sternocleidomastoid? Now, first of all, what is the concept of this branchial fistula? I hope you people have studied that. I told you ectoderm is going to form what's a cleft, and in total you'll be having like 4 clefts. The first cleft, ectoderm will be actually invaginating inside, and the first cleft is going to form the external acoustic meatus along with the outer layer of tympanic membrane and all. So the first cleft, from here there will be external acoustic meatus and all. But after that, the second cleft and the third cleft and fourth cleft will be normally closed. Why? Because this arch, which arch? Second arch growing faster, and it will be overlapping that one, it will be closing. That is the reason why after this external acoustic meatus, you don't find anything developing from the second, third and the fourth cleft over here. It is completely closed there. And now, while closing, you can clearly see that there is a space here, and that space is nothing but sinus, and that sinus is cervical sinus. Now, you and me, in your body and in my body during development, this has been completely closed. Thank God. Okay. And because it is completely closed here, and your neck and my neck over here is absolutely normal. But in some people, unfortunately, it is not closed completely, and that remains as a fistula, and that is known as what, guys? Branchial fistula. That is known as what? Branchial fistula. Understanding? So branchial fistula, now let us come back to the question. Which of the following pharyngeal arch give rise to development of a branchial fistula? Okay, extending from, yes, yeah, which arch is actually developing there? Actually speaking about the arch right now, sir. Yes, it is the second arch. So normally what should happen, because of the overgrowth or the faster growth of the second arch, it has to be covered completely and closed. But if it is not closing that completely, then what is going to happen? Yes, it is going to remain as a fistula, and that fistula is known as what, guys? Branchial fistula. Yes, sir. Again, so I hope you are able to correlate with our regular classes and all, guys, how we are clinically correlating it as well. Okay, that fistula is known as, if it persists, cervical sinus, if it persists, there is nothing but branchial fistula. Which among the following is or true regarding the anatomy of the parotid gland, guys? Okay, true. Stenson's duct opens near the second molar. No, it is absolutely false. Wrong. Why? Because it is not going to open near second molar. It is going to open near upper, not third molar. It is going to open near upper second molar. Yes, yes. Very nice, Anshul Sharma. Very good, very good. Facial nerve branches divide into superficial and deep parts. Yes, the facial nerve and the branches of that will divide the parotid gland into superficial part and deep part. Yes, I told very clearly during our classes that, remember, facial nerve is not going to supply to the parotid gland. Most of the students will be having a misconception that facial nerve is piercing that gland and passing from there. So it is gonna, supply to the parotid gland. No. It is going to pass through a separate plane that is known as the Pattis plane over there. Is it okay? So it is dividing that into superficial part and the deeper part. Deep part projects into the parapharyngeal space. Deep part, it is actually related to the pharyngeal wall. Deeper part. Okay, so it is projecting into the parapharyngeal space there. Okay, it is related to the pharyngeal wall over there, guys. Okay, and then pierces by retromandibular vein and facial artery. No, it is not piercing. Retromandibular vein is correct, but facial artery, facial nerve is going to pierce. See, remember, parotid gland will be actually pierced by, number one, it is pierced by facial nerve, that every person knows that one, sir. Number two, it is pierced by retromandibular vein over here, and number three, it is pierced by external carotid artery. So it is not facial artery. Facial artery is not going to pierce. Facial artery is given here only in the submandibular region, taking a turn and coming from here. So facial artery is not going to pierce the parotid gland. It is pierced by external carotid artery, guys. I hope we got all the statements over there. A patient presented with a normal eyesight is normal, but absence of direct and consensual light reflex. Light reflex is absent. Okay, which of the following cranial nerves is suspected to be, yes, involved in this one? See, whenever it comes about the light reflex, I hope you know about that sphincter pupillae muscles, sphincter pupillae muscles and ciliaris muscles for accommodation reflex and the light reflex over there, and they are under the control of your parasympathetic nervous system. And parasympathetic nervous system, I hope you all know the nerve supply. It will be like 3, 7, 9, 10. And out of that third nerve, oculomotor nerve, Edinger-Westphal nucleus. I told you, all the cranial nerves has been dealt in detail. So the third nerve, oculomotor nerve, Edinger-Westphal nucleus, the fibers which are coming from there are going and supplying towards the sphincter pupillae muscle and the ciliaris muscle. They are concerned with the light reflex, and if there is absence of that light reflex, of course the nerve involved will be your oculomotor nerve, without any doubt over there. Yes, absolutely correct. I think many of them are answering correctly over there. Dr. Bharat, Alia Khan, Sneha Patel, Komala, Kanika Naik. Yes, very good. Yes, of course, Dr. Roy, efferent will be coming from the oculomotor nerve. Okay. Next one. When we are dealing with the reflex, any reflex, there will be like afferent, and then there will be a center and then efferent there. Yes, Dr. Roy says correctly there. The efferent arm will be coming from where only? The oculomotor. Afferent obviously will be the optic one. Okay, because the light reflex, light has to come in. Optic nerve. A patient has lost the ability to discriminate between 2 points presented simultaneously to the skin on the left hand. 2-point discrimination, fine touch on left hand. Okay, neurological evaluation is most likely to reveal a lesion in the. See, first of all, try to recall in your mind. Fine touch, all this 2-point discrimination and all this will be carried by dorsal column. Dorsal column, you'll be having fasciculus gracilis and fasciculus unitus. There'll be 2 tracts. Now, my dear doctors, try to recall. Hello. For example, if this one is your midbrain and followed by this is the pons here, and this one will be the medulla oblongata followed by spinal cord. Okay, pons and medulla oblongata followed by spinal cord. Now in the spinal cord, you'll be having that posterior median sulcus, anterior median fissure, and then there will be H shape or butterfly shape gray matter in central canal. Now the fibers which are beginning from the lower limb, they are going to form what, sir? Fasciculus gracilis, and from the upper limb fasciculus cuneatus. Whatever. If they are coming from upper limb, okay, for example, this is the left side here, sir, the left hand upper limb. Now those fibers are going to enter from the dorsal side, dorsal root ganglion, and they are neither going to cross in the spinal cord. Remember 2 points here, appreciate 2 points here. They will not cross in the spinal cord, and they are not even going to stop in the spinal cord there. Those fibers are going to ascend up on the same side, and they will finally go and end where? They are going to actually end where, guys? They are going to end in the medulla oblongata. Okay, so obviously if it is coming from upper limb, it is going to form fasciculus cuneatus, and then in the medulla oblongata, that nucleus will be cuneatus nucleus. I repeat all these points again, guys. I think I told you so many points at once. So the fibers coming from upper limb, they are going to enter the dorsal root ganglion, and after going to enter from there, they're going to ascend up on the same side, forming which tract? Fasciculus cuneatus, and that is going to end in which nucleus, guys? Cuneatus nucleus in medulla oblongata. Now from here, the fibers are going to cross on the other side, and then they are going to ascend up. और मैंने आपको clearly बताया था, I told you very clearly, here in the brainstem, that is going to form what's a lemniscus. Which lemniscus? The medial lemniscus. So you can appreciate one thing here. Dorsal column, that is going to continue as which lemniscus there, guys? Dorsal column tracts. They are going to continue as medial lemniscus. And remember, crossing will be taking place in medulla oblongata, not in the spinal cord. The crossing is taking place in medulla oblongata. Yes, Dr. Bharat. Yes, Dr. Roy. Very good. Now, apart from that, chalo, I told you everything, how the tract is crossing. I told you the anatomy part of that. I told you the course of the tract, how it is crossing. Okay. But what is carried by this one, guys? Dorsal column. Remember, dorsal column, we are actually having two tracts, fasciculus gracilis as well as fasciculus cuneatus are there. And both of them are going to carry, yes, number one, fine touch. And not only fine touch, number two, vibration sensation. And then number three, stereognosis. And not only stereognosis, guys, even proprioception is also carried by that one. Okay, that too, conscious proprioception is carried by that one. Okay, now. Fine here. So fine touch, the vibration, the stereognosis and proprioception all will be carried by the dorsal column. Dorsal column is going to carry that one. Chalo. Now keeping all this information in our mind, let's go here, my dear friends. The person has lost the ability to discriminate between the 2 points on left hand. Now, he's lost the ability to, for the 2 point discrimination. So let us see what is the injury right now. Medial lemniscus on the right side of the pons. Yes, possibility here. Dorsal column on the right side of the spinal cord. No. See, dorsal column, if it is injured on the right side, then it should be like right hand, not the left hand. Because dorsal column is not, in the dorsal column, the tract is not crossing. The crossing in medulla oblongata. So, ye galat hai, that is wrong. Fasciculus gracilis on the right side of the medulla. Fasciculus gracilis, it is actually from the hand, right? Hand, it should be like fasciculus cuneatus. So, ye to absolutely wrong hai. Spinothalamic tract, no way. That is not for the fine touch. Spinothalamic tract is actually for the crude touch and pressure. Pain and temperature by lateral spinothalamic tract. Crude touch and pressure is by the anterior spinothalamic tract. So absolutely the answer is medial lemniscus. Wow. Very good, Dr. Roy. I hope you are getting it. Okay. चलिए जी बढ़िया. Very good, Dr. Muskan. Very good, Dr. Roy. Very good, Dr. Komala. Bharat. Very nice. I hope you got the clarity now. I hope the concept is getting revised in your mind. अगर आपने पहले पढ़ा है तो. Yes, next one. Olive is seen in which part of the brain? Now, after all those clinical questions and all those things, I just wanted to keep one simple question in the middle so that you don't get fear. Olive is seen in which part of the brain, sir? Yes, I hope you all have studied about the brain stem. brain stem, and this is actually the ventral aspect of the brain stem, guys. And in the ventral aspect of the brain stem, this one will be your midbrain here, and this big structure, bridge-like structure, is pons here, and this part is actually the medulla oblongata, guys. That is medulla oblongata. And in the medulla oblongata, you are actually able to see this pyramid here, and this is a pyramid here. That elevation is known as pyramid there. And this elevation here is olive and olive here, guys. So what is the reason? Why is this olive formed there, guys? What is the reason? Why is that elevation olive formed there? Remember, the elevation olive is formed because beneath that there will be olivary nucleus, inferior olivary nucleus will be present over there. So beneath the olive will be having inferior olivary nucleus. Because of that, that elevation olive will be formed there, guys. Okay? Chaliye, badhiya. So whatever it is, you are able to see here, olive is seen in which part of the brain? We are able to see that in the medulla oblongata. Simple thing. Hope it is clear, guys? Yes, absolutely correct. A highly agitated 54-year-old man is brought to the emergency department by his family because he is unable to effectively communicate. There is a problem with the communication, speech. Okay. He speaks clearly and with conviction, but his sentences are incomprehensible. Okay, there is a problem with comprehension, understanding. He does not appear to understand the doctor's questions. Does not follow oral or written instructions also. Cannot repeat simple phrases. So simply by reading all these things, you are clearly able to understand there is some problem with the speech of the person. Branch occlusion of which of the following arteries is most likely responsible for this patient condition? First, you people try to recall from our regular classes, from our videos, you try to recall Broca's speech area number 44 and area number 45. That will be in the inferior frontal gyrus. Whereas the Wernicke speech area here 39 and 40 are present over here. Basically, tell me, Broca's speech area and the Wernicke speech area, whatever, both of them are present on which surface? This is the superolateral surface. That is superolateral surface of cerebral hemisphere. Or chalo, if you are not able to understand on this side here, let me draw the coronal section of this one. For example, I am drawing the diagram in coronal section. So I am drawing the diagram in coronal section, guys. So how many surfaces do you have? One will be the medial surface, another one is the inferior surface, another one is the superolateral surface. So there are like three surfaces of cerebral hemisphere. There will be medial, superolateral and inferior surface. And I hope if you will have learned about the circle of Willis along with the branches, you know very well, cerebral arteries, there will be of three types: anterior cerebral, middle cerebral, and then there will be posterior cerebral artery. And out of these three, remember, anterior cerebral artery is the chief artery of the medial surface. Middle cerebral artery is the main artery of superolateral surface. And then finally, the posterior cerebral artery is the main artery of the inferior surface. Posterior cerebral artery is the main artery of the inferior surface. Okay, so now correlate these two concepts. The arteries which we have learned in the circle of Willis topic, and then, my dear friends, the Brodmann areas, the speech areas, the Wernicke speech area and the Broca speech area. Is it okay? So therefore, now which artery is involved here? The middle cerebral artery. If this artery is occluded, then the superolateral surface will be affected. Yes, my dear friends, what is going to happen? The speech areas are going to get affected. So therefore, the exact answer, the answer for this one should be the middle cerebral artery. Option C. Middle cerebral artery should be the option. Perfectly right. So the questions which I have given you in this Elite test series, the clinical questions, guys, and those clinical questions, and that too like 2 or 3 concepts you have to actually understand and answer these questions, guys, these type of questions. Okay, so chaliye aage badhte hain. So let's go ahead now. A 34-year-old man comes to the clinic with 3-week history of difficulty hearing. He's having a problem hearing. He finds it increasingly difficult to tolerate everyday sounds. Oh. He also complains of ear pain and often avoids public places as a result. Stapedial reflex, loud sounds and all those things. Okay. The patient has no past medical history and takes no medications. Injury to which of the following cranial nerve is most likely responsible for his condition? Just now I told you, 7th cranial nerve I have explained you in detail, and I think I have actually given you 3 clinical questions based on like 3 concepts of 7th nerve. I gave you one clinical question related to lacrimal gland supply, greater petrosal nerve, and I gave you one clinical question related to the submandibular gland, salivary glands, chorda tympani branch, and now one more clinical question. A person having problem with stapedial reflex, hearing loud sounds and all those things, and seventh nerve will give nerve to stapedius muscle. That is why which cranial nerve is involved here, sir? The facial nerve. Wow. So based on facial nerve, already like three clinical questions are given to you on different branches of the seventh nerve, guys, and how to deal with them you can clearly see in the questions given there. Moving ahead. Now one more question here. Integrating of anatomy with the ENT, guys. The muscles of larynx, extremely important for your NEET PG exam. Okay, they'll be constantly asking, and that too in the NEET PG exam they'll be giving you the image based questions. So don't mug up just the name of the muscle and function of that one without looking at the muscle, guys. Don't just simply mug up the name of the muscle and the function of that, name of the muscle and action of that. No. Don't do like that. You should be able to even identify that muscle. See and identify that muscle, guys. Okay. Now, what is a mismatch regarding this one here? First of all, what is this muscle A here, guys? Try to identify. What that muscle A there? Yes, that muscle A you can very clearly see there. It is between the thyroid cartilage and the arytenoid cartilage over here. So thyroarytenoid muscle. And thyroarytenoid muscle, when it is trying to, contract, when the muscle contracts, these two cartilages will come closer. They're going to come closer, and when they're going to come closer, the vocal cords, they're not like stretched, they're actually relaxed. So therefore A will actually help in relaxation of vocal cord. Absolutely correct combination, correct match. Then after that, what is it B, guys? B muscle, you can clearly see it is between the two arytenoid cartilages, between the two arytenoid and arytenoid cartilages, and that when that muscle is going to contract, what is going to happen? Even that cartilage will also come closer. So therefore, what is going to happen? The space between the vocal cords is known as rima glottidis. I hope you know that. Let me draw this diagram separately here to make you understand more clearly. So these are the arytenoid cartilages and these are the two vocal cords, guys. And now the space between the space between these vocal cords here is nothing but your rima glottidis. But in that rima glottidis also, my dear friends, this space between the vocal cords, and yes, there is a space between the two cartilages. Okay, and the space between the two vocal cords will be closed by, between the two vocal cords here will be closed by the lateral cricoarytenoid muscle when it goes to contract. The lateral cricoarytenoid muscle will contract, okay, which is given in the the diagram number C, third diagram there. So in the third diagram you can clearly see the lateral cricoarytenoid, and if that muscle is going to contract, what is going to happen? The vocal cords are going to come closer. But the problem is that only vocal cords will come closer, but the space between the cartilage, between the two arytenoid cartilage will still remain open. You can see in the diagram C there. So this space will still remain open there. Understanding? I repeat that again. If you see the diagram number C, the lateral cricoarytenoid muscle, when it contracts, only vocal cords are coming closer, but the space between the two cartilages still remain open. So through that space, you can actually do whispering sound. I think that is your favorite muscle in the in this age group of students, Yes, mostly you'll be using this muscle only, lateral cricoarytenoid muscle, calling your girlfriends and boyfriends in the night time, hello, something like that. That's your favorite muscle. So cricoarytenoid muscle, when it contracts, that is the muscle of whispering, guys, because some small space is still remaining open there. So B muscle, that is actually interarytenoid muscle or transverse arytenoid muscle. That transverse arytenoid muscle even closes that space also. So B, closure of intercartilaginous part of rima glottidis, absolutely correct. So it is closing that small space also. Is it okay? Then C, yes, already explained you. C is actually the muscle of whispering. C is nothing but lateral cricoarytenoid. When it contracts, a small space still remaining, muscles of whispering. And D is actually the posterior cricoarytenoid, and posterior cricoarytenoid is for when this is going to contract, it's going to take the vocal cords away. You can clearly see in the picture there. And when it is going to take the vocal cord away there, That is nothing but abduction of vocal cords. Abduction of vocal cord. It is abductor of vocal cord, not for opening the inlet. Yes. Okay. So it is for abduction of the vocal cords, not for opening the inlet of larynx. And opening of inlet of larynx is done by a separate muscle, and that will be your thyroepiglotticus muscle. Thyroepiglotticus muscle. Yes, I hope you're understanding the functions here, guys, and you can understand the functions in more detail in my lecture on DocTutorials app, guys. So go and watch the video, you'll enjoy more there with all these functions I've told very clearly, very clearly. It's not about just the name and the action, Yes, everything in a conceptual manner, like how to understand how is the attachment of the muscle, why it is abduction, why it is adduction, everything has been very clearly understood, guys. Okay. Yeah, Dr. Ankit. Yes, absolutely correct. That is the safety muscle of the larynx. Cerebellar nuclei are located anatomically medial to lateral. See, normally na, thoda sa tricky hai. This is like little bit tricky here. If this is your cerebellar hemispheres, inside the cerebellar hemisphere you'll be having dentate nucleus, then emboliform, then globosal nucleus, and then fastigial nucleus. Doctors eat good food. That is the mnemonic every student remembers. Doctors eat good food. Dentate, emboliform, globus, fastigial. Every student in the class, they remember, or they have the habit, consciously, subconsciously, they have the habit of remembering lateral to medial. There's a little bit trickier. It's medial to lateral. So this question I have given you just to make you alert in the exam. You should be very much careful. Whatever usually you study in the class, it cannot be in the same order all the same time. So just trying to check your alertness during the exam that you have given in our elite test series at DocTutorials. Okay. So I was just trying to check your alertness over there. Yes, remember it's fastigial, globose, emboliform, and then dentate. So option B. Option B, sir. It's medial to lateral. Be careful there, because usually what will happen when some questions which most of the students will be definitely learning and going to the exam. हाँ यार ये तो पढ़ाई था हमने, है ना? We have already learned and went to the exam. We know this one. So they will not even see the order also. ये पढ़ते ही नहीं है. They don't even read this one. They don't even see the order also there. They are like, oh, cerebellar nuclei. Jump to the options. Cerebellar nuclei ये तो अपने को पता ही है ना? And you can see the option there. Definitely you'll be having that one, guys. So please be very, very careful with this kind of questions. Please be active. Okay. चलिए सर, बढ़िया. Next one, guys. Hypoglossal nerve is related to which triangle? Hypoglossal nerve is related to which triangle? I am speaking actually about the 12th cranial nerve, है ना? So my dear doctors, for example, if this one is medulla oblongata and continuing down into spinal cord, if this is your medulla oblongata, inside the medulla oblongata, you'll be having that hypoglossal nucleus. The hypoglossal nerve is going to come out there, and then it is going to take a dip here, and then finally the 12th nerve will go and supply to all the muscles of your tongue except the palatoglossus. आपको पता है? It is going and supplying to the muscles of tongue. So let us try to correlate with our body here. The best way to learn is that apply this diagram on your body. So there will be medulla oblongata here, and from the medulla oblongata the 12th nerve is going down like this and then going and supplying to muscles of tongue. So I'm going to turn here exactly like the diagram on the screen. So I'm going to turn here, medulla oblongata here, the tongue here, and this is going to take a dip like this and go and supply to the tongue there, guys. Perfectly fine. And now I am not telling only about the nerve now with respect to triangle. You know very well what is this triangle here? Digastric triangle here. Digastric triangle. And what is this triangle here? That is your carotid triangle. Carotid triangle, guys. Okay. It's speaking about the anterior triangles of the neck. Anterior triangles of the neck are anterior triangle of the neck is actually divided into like 4 triangles there, guys. Fine here, guys. Anterior triangle of the neck, like it is divided into 4 triangles. Out of that, this will be digastric triangle, and then there will be carotid triangle, guys. So therefore, remember the 12th nerve is going. The 12th nerve is going in digastric triangle, then the carotid triangle, then again coming to digastric triangle. If you are interested here, I'll show you the diagram. Look at this diagram, guys. Look at this beautiful diagram here now. Now in this diagram, this is your hypoglossal nerve, the 12th nerve. Okay. So that is your hypoglossal nerve, so the 12th nerve here. And if you are able to see the 12th nerve, it's taking a turn there. Can you see that? Can you see that the 12th nerve is taking a turn in front of all the structures in carotid sheath there? So it's taking a turn there here. So it's in digastric triangle, and then again in the carotid triangle, then again it will go back into the digastric triangle. So you have to always, in the triangles of the neck, always you have to remember, in the triangles of the neck, you have to always remember that yes, it will be it will be actually present in the structures which are passing from one triangle to another triangle. You have to learn that one, guys. So my dear doctors, welcome back here. Hypoglossal nerve is yes related to both the triangles. So the correct option is C here, sir. So it is present in digastric triangle also as well as the carotid triangle also. Hope you got this very clearly. Priti Raj is asking, पिछले क्वेश्चन में B था या C था? Priti Raj, पिछले क्वेश्चन में यहाँ पर ना actual arrangement is dentate, emboliform, globose, fastigial. आपको पता होगा कि we are going to learn this with the mnemonic as doctors eat good food. Doctors eat good food, ऐसे याद रखते हैं, ठीक है ना? So, but the problem here is that it is medial to lateral ना. So first it will be fastigial, okay, and after that it is, you know, so it should be fastigial, globose, emboliform, and dentate. Okay, Prithviraj. Answer should be C here, है ना? Fastigial, globosal, emboliform, and then dentate. Fine. Okay, fine, sir. I'm extremely sorry here. Okay, fine. चलो, तो hypoglossal nerve is present in both the triangles, so digastric triangle as well as the carotid triangle. Thank you, Priti. Okay, and ये भी clear हो गया. I think this concept is very clear, guys. Okay, hypoglossal nerve. Thank you, Aryan. Now moving ahead, which of the following is a phrenic nerve? Now out of this, all these nerves, we have to identify the phrenic nerve. See, I'll tell you one thing, very simple thing. These structures are actually enclosed in your favorite carotid sheath. Carotid sheath. I think you people have learned carotid sheath in your first year MBBS days every time because it's one of the most important topic. Now inside the carotid sheath, you'll be having the carotid artery. This is your like common carotid artery here. This is the internal jugular vein, and sandwiched between the two, the artery and the vein, between the two, there will be vagus nerve, sir. So this B should be definitely the 10th nerve. Sandwiched between the two, that is your vagus nerve, guys. That is your 10th nerve. ठीक है ना? Fine here. Chalo, one thing is very clear. Apart from that, if you people have learned the relations, anterior and posterior relations of the carotid sheath, posteriorly you will be having sympathetic trunk. So this D here should be your sympathetic trunk, sir. D should be actually your sympathetic trunk, guys. Okay. So this one will be the sympathetic trunk. Fine. Now, my dear doctors, after that, what is this D here right now? You can clearly see that D is passing in the tracheoesophageal groove. It is passing in the tracheoesophageal groove, guys. Okay. So that D is actually passing in the tracheoesophageal groove, guys. So therefore that one should be definitely a recurrent laryngeal nerve. Recurrent laryngeal nerve, guys. Okay. And then finally, what is left out here? A, this one is definitely your phrenic nerve. That is phrenic nerve, and it is very easy to identify, guys. That phrenic nerve lies anterior to your scalenus anterior muscle. So whatever muscle that you're able to see here, this is scalenus anterior muscle. It is right in front of that one. That is your phrenic nerve. That is your phrenic nerve, guys. So option A, which of the following is the phrenic nerve? A is the phrenic nerve here, guys. So I've given you this question. Why? Because this image was given in your NEET PG exam. Yes, as an image based question. So in this image, mostly the students will be able to identify the structures like, you know, subclavian artery, subclavian vein, all the other branches, common carotid, internal jugular. Those major structures every student will be able to identify. But yes, just before the exam, for the sake of revision, I have given in this one all the nerves, guys. So you are able to identify all the nerves right now. So 10th nerve, how to identify? Sandwich between the artery and vein. And behind the carotid sheath, definitely there will be sympathetic plexus, sympathetic trunk. And then between the tracheoesophageal groove, you can clearly see the tracheoesophageal. That will be the recurrent laryngeal nerve, and then the phrenic nerve in front of the scalenus anterior. So wherever my students will be finding difficulty, like the identifying nerves will be difficulty, so those things I have to actually have tried to cover here. Moving ahead, guys. True and false regarding the innervation of marked muscles. Okay, so whatever marked muscles are there here, let us see what is the nerve innervating them, guys. First of all, A. I'll tell you one thing here, guys. There will be anterior belly of digastric, and then there will be posterior belly of digastric here. I think you people have learned about the pharyngeal arches, derivatives of pharyngeal arches. Pharyngeal arch number 1 is supplied by mandibular nerve. Pharyngeal arch number 2 is supplied by facial nerve. Facial nerve. So I hope you all remember very well. Okay, in the pharyngeal arches topic, like facial nerve is supplied to like whichever muscles, those muscles will be derived from the second pharyngeal arch. Facial nerve is supplied to whichever muscles, those muscles are derived from the second pharyngeal arch. So therefore, my dear doctors, remember the posterior belly of digastric along with stylohead, both the muscles are actually derived from second pharyngeal arch, supplied by seventh nerve. So therefore, A, it is supplied by seventh nerve. Perfectly correct. B, you can clearly see there, it is actually written as B is supplied by external laryngeal nerve. It cannot be external laryngeal nerve. Why? Because external laryngeal nerve will be supplying to the only muscle of larynx present outside. I have said this golden rule n number of times in my classes. N number of times in my classes I have said this one. In my classes, that is a golden rule. Okay, in larynx, the only muscle present outside, that is your cricothyroid, and that is supplied by external laryngeal nerve. And no way, the moment you look at that muscle, it is not at all cricothyroid muscle. It's coming and getting attached to the hyoid bone, thyrohyoid. No, it is not supplied by external laryngeal nerve, guys. Next, C here. C is actually the levator scapulae muscle, which is in the floor of the posterior triangle. Yes, in the floor of the posterior triangle, that is levator scapulae, the largest one. When I taught you about the triangles of neck in our DocTutorials videos, in our DocTutorials app, triangles of neck जब मैंने बताया था आपको, in the posterior triangle of the neck, the floor, largest muscle, the muscle which is contributing the largest is levator scapulae. And yes, of course, in upper limb topic we learned levator scapulae will be supplied by dorsal scapular nerve, brachial plexus coming from the C5, dorsal scapular nerve. And D is actually omohyoid, and yes, of course, omohyoid is supplied by what, sir? Ansa cervicalis. You remember ansa means loop here. Ansa means loop here, and that ansa cervicalis will actually give like how many branches, sir? 3 branches, and those 3 branches will be supplying to sternothyroid, sternohyoid, and omohyoid. Sternothyroid, sternohyoid, and omohyoid. And omohyoid is supplied by, yes, of course, ansa cervicalis. So I hope you are easily able to identify which is true statement and which is a false statement. It is about the muscles of the neck and supplied by which nerve cell. चलो आगे बढ़ते हैं. Now, actually, till here, if you have observed the questions, those questions were mostly related with the neuroanatomy and head and neck. And neuroanatomy and head and neck, we have actually planned in test 1, LI test 1. I told you, LI test series, we have conducted like 3 tests for anatomy. 3 tests we have conducted for anatomy. So in the test 1, I have divided the topics into like, head and neck and neuroanatomy topics in test 1, guys. And now welcome to the test 2, in which it was mostly about the upper limb, lower limb, and histology part and general anatomy part, the joints, epiphysis and all. Fine. So a boy playing soccer has suffered trauma to the medial meniscus. From a blow to the lateral aspect of the knee. So from the lateral aspect there is a hit and the medial meniscus is gone and the knee has become unstable. What are the other structure most likely to be injured? See, I hope you people have learned about this in orthopedics. So I'm trying to correlate anatomy with orthopedics right now, sir. In orthopedics, there is a syndrome known as terrible triad syndrome. Yes, in orthopedics, I hope you have learned that there is a syndrome known as the terrible triad syndrome, guys. Terrible triad or unhappy syndrome. And the terrible triad syndrome, what is going to happen? They'll be hit from the lateral side. You can clearly see here. This is the lateral side here. This is the medial side here. Tibia and fibula. If there is a hit from the lateral side, then what is going to happen? The medial meniscus will be torn, okay, along with the medial or tibial collateral ligament, or the medial one, and then the anterior cruciate ligament. These three are gone, and that is why it is a unhappy triad or terrible triad. Very good, Dr. Bharat. Very good, Dr. Bharat. Syed Zainul Mehdi, hello sir. Hello Zainul. Yeah, I'm good, Zainul. By the way, thank you sir. Cleared my FMG in the very first round by Chris and Solid Anatomy. Thank you, Zainul. God bless you, dear. God bless you with lots of success in your life. You go ahead in your life. Come out with happy colors. Okay. So there is a terrible triad. So already it is showing here medial meniscus is gone. So what else can be gone, sir, in terrible triad? Deltoid ligament, no. Lateral meniscus, no. Anterior cruciate ligament, yes. Patella ligament, no. So what else can be gone? Anterior cruciate ligament, sir. Okay, na? Chalo, next one. A healthy young athlete sitting at the table with the knee at 90-degree flexion. What will happen when they fully extend the knee? See, this question was actually this question is actually about the locking and unlocking of the knee joint. Locking and unlocking of the knee joint, guys. Okay. So I hope most of you are able to recall, whoever are preparing for the NEET PG, and the other students who have actually completed their FMG and preparing for NEET PG right now, you are getting like what are the new concepts which we normally don't teach in the FMG. So those concepts which are like untouched in FMG, now you are able to see here how you are able to, you know, correlate between the anatomy and other subjects, guys. Yeah? Yes, very good. So my dear friends, a healthy young athlete sitting on the table with the knee at 90-degree flexion. See, first of all, I'll tell you a normal thing. When you study about the locking of knee joint, locking, normally, right, for example, you are sitting there, I'm sitting here. In sitting position, our knee is actually flexed. Now, when you're trying to stand up, your knee will be extended. And during extension, what is going to happen at the last 30 degrees? During the last 30 degrees of extension, your knee will be locked. That is known as locking of knee joint. Okay. Right now in this online session here, I cannot stand and show here. Normally in the live classes, will be standing and showing here exactly. So during locking, what will happen? There are two types. One, you can lock the knee when your foot is on the ground. For example, you are standing up and you're locking the knee joint. So your foot is on the ground. But there is one more way of locking the knee joint. Just observe this diagram here. Yes. In this diagram, you can see the person is actually extending or, you know, taking the foot up. So even though the foot is off the ground, this is like off the ground. It is not on the ground there. Even though it is off the ground, at that time also the knee joint is locked there. Yes, of course, you can clearly see the knee joint is locked. Understanding? So the mechanism is totally different there, sir. In the first one, which I told you, when the person is standing there on the ground, with the foot on the ground, I'm telling you now, sir, it is due to the medial rotation of femur. Medial rotation of which bone? Femur on tibia. There will be a slight confusion here. That is the reason why I'm repeating it. Don't think that, you know, why is Azam sir repeating 2-3 times like this. When the foot is on the ground, there will be medial rotation of femur on tibia. So you just remember like the olden days type of lock. In the olden days, we used to have a lock, then the key, and key हम कैसे घुमाते हैं medially to lock it. Unlock again उल्टा है ना, to lock it medial. So medial rotation of femur on tibia. Olden days वाला lock. Nowadays तो we are just having like card here है ना, automatically just card ऐसे touch करो unlock हो जाता है. तो yes, medial rotation ऐसे याद कर लो. Remember like this. That's a trick to remember when the foot is on the ground. And exactly opposite will be, yes, when the foot is off the ground. Like this picture here, sir. On the ground, so everyone will study. Now this kind of picture here, yes, when the foot is off the ground, 90 degrees, you know, flexion से वो क्या कर रहा है सीधा सीधा, he is like, you know, fully extends the knee. When the person fully extends the knee, then what is going to happen? Totally opposite. Opposite what? Then the tibia will rotate laterally. Lateral rotation of tibia, yes, over the fibula. So movement of tibial tuberosity towards the medial border of patella. Movement of tibial tuberosity towards the lateral border of patella. So what is the right option, sir? Come on. No, Bharat, Dr. Bharat, that's what Bharat I'm trying to clarify. See, Bharat, whatever you have learned during your MBBS days now, that is only for, in our MBBS days also, they will be just teaching us about the locking when you're standing on the ground. When you're standing still on the ground and the foot is on the ground. But this question is not about the on the ground there. It is about off the ground. So don't always say that, it's only medial rotation. When the foot is on the ground, medial rotation of femur on tibia. That is right, absolutely, as you said, Bharat. But when the foot is off the ground, when the foot is in the air, at that time the locking totally opposite. Yes, the movement of tibial tuberosity towards the lateral border of patella. Lateral rotation of tibia on the femur. Okay, I hope you got the concept very clear, guys. Yes, and yes, this was also asked as an image-based question once in the AIMS exam also. Okay, it was an image-based question in the AIMS exam. Next one. An 83-year-old man has trouble walking. As his physician of his, he is asked to stand on his right foot and his left foot is dropped. So, which of the following nerve is most likely damaged, causing the problem? The person is asked to stand on the right foot, but his left foot is going to drop. And I hope this is like very famous one. Every student will be knowing this one. This is a question regarding lurching gait, and Trendelenburg sign is positive in this one. Thank you, Dr. Bharat. Yes, lurching gait, and which sign is positive in this one, guys? Yes, the Trendelenburg sign will be actually positive in this one here. Very nice. लेकिन यहाँ पर दिक्कत क्या होती है पता है? The problem here is that if the superior gluteal nerve on the right side is gone, then the gluteus medius and minimus muscle on the right side are gone. Medius and minimus. And then which opposite side, like contralateral side, left side, that is something important. On the left side, this hip will be actually drooping, sir, because it is unable to abduct the hip joint. Gluteus medius and minimus will be having the function of abduction of the hip joint. So if the muscles on the right side are paralyzed, then the left side hip will be actually dropping, guys. Okay, so therefore we'll come back here. Asked to stand on his right foot, his left hip drops. If the left hip is dropping, remember contralateral side nerve is gone, opposite side, that is important. If left hip is dropping there, then the right superior gluteal nerve is gone, sir. That is the reason why I have given you this question. You should know the side. Right superior gluteal nerve is damaged. Next concept now. A patient is unable to invert the foot, indicating the lesion of which of the following nerve? I hope you all know about inversion and inversion of the foot, guys. Yes. In this picture, you can very clearly see, if you elevate the lateral border of the foot, then what is going to happen? That is known as eversion. If you elevate the medial border of the foot, that is known as inversion. Now, eversion should be definitely done with the lateral compartment muscles. And in the lateral compartment of the leg, you'll be having peroneus longus and peroneus brevis. And both these muscles are supplied by superficial peroneal nerve. I repeat again, eversion is elevation of lateral border of the foot, and elevation of lateral border of the foot is done by two muscles, peroneus longus and peroneus brevis, and both of them are supplied by superficial peroneal nerve. Whereas inversion is done by the tibialis anterior muscle and tibialis posterior muscle. Tibialis anterior muscle and posterior muscle. Tibialis anterior in the anterior compartment supplied by deep peroneal nerve, whereas tibialis posterior will be in the posterior compartment, that is supplied by the tibial nerve, guys. I hope all my dear students, all my students who attended my class on DocTutorials app here, they know my golden rule. Yes, Azam sir's golden rule. I hope you remember. I have given you for upper limb all the different compartments which nerve will be supplying, and for the lower limb, yes, compartments which nerve will be supplying. That's our way of studying, hai na? So our golden rule, and with that golden rule, you can remember these nerves like in 2 minutes. You'll be able to remember all these nerves, guys, hai na? So if inversion is lost, tibialis anterior, tibialis posterior not working, then there should be deep peroneal nerve and tibial nerve gone, sir. Okay. So therefore, my dear doctors, if unable to invert, inversion is gone, then deep peroneal nerve and tibial nerve is gone, sir. Very good, sir. Very good, Dr. Ankit. Let's go ahead now. A football player has suffered severe trauma to the lateral part of the left leg. Lateral part of the left leg just below the knee. He drags his left toe when he walks and cannot feel. Drags his left toe and when he walks and cannot feel on the dorsum of the foot. He's dragging the left toe. Means what, sir? Lateral compartment is gone, and lateral compartment is supplied by which nerve only? Superficial peroneal nerve. And the same superficial peroneal nerve also supplies to the skin covering the dorsum of the foot. So this is the foot here, the plantar region, and this is the dorsum. And dorsum will be supplied by superficial peroneal nerve. Which of the following will be intact? Which of the following will be intact actually? Dorsiflexion, eversion, cutaneous sensation on the medial side of the leg, and then the cutaneous sensation between the great toe and the second toe. What do you say? Which one will be gone? Which one will be intact? Come on guys. See, dorsiflexion, yes, absolutely. The only thing which will be intact here, Dr. Komala, will be the cutaneous sensation on the medial side of the leg. Why? Because on the medial side of the leg, the medial side of the leg will be supplied by saphenous nerve, and saphenous nerve is actually a branch of your femoral nerves. That is the only thing which will be intact here. Remaining everything will be gone. Why? Because when there is an injury towards the lateral side of the leg, you'll be having fibula, and near the neck of the fibula there will be common peroneal nerve. And when common peroneal nerve is injured, then both of them will be gone, sir. The deep peroneal nerve is also gone, as well as the superficial peroneal nerve is also gone, sir. So I repeat again, the injury is lateral side of the leg, just below the knee, near the neck of the fibula. There is a common peroneal nerve. And when common peroneal nerve is injured, then deep peroneal nerve is also injured, then superficial peroneal nerve is also injured. Both of them will be gone, sir. Is it okay? So when both of them are gone, all the dorsiflexion is lost, eversion is lost, deep peroneal nerve is also supplied to the skin between the great toe and second toe. That is also gone. So that is the reason why. The only thing which is intact is all the sensory supply to the medial side of the leg, sir. A patient came with a history of fall. On an examination, there was a tenderness between the extensor pollicis longus and brevis. Okay, the person fell down and there's a tenderness between the extensor pollicis longus and brevis. The likely lesion is, if you're able to recall the boundaries of anatomical snuff box. Okay. On the lateral side, you'll be having like two ligaments there, extensor pollicis brevis and then abductor pollicis longus. And on medial side, you'll be having only extensor pollicis longus. Now a person fell down and there is a tenderness between the extensor pollicis longus and brevis. That means in the anatomical snuff box. And you know very well, yes, it is on which side, sir? Here. So therefore, the carpal bones, if you remember, she looks to Pterion. So what is there in the floor of that one, guys? Scaphoid. And scaphoid bone is most commonly fractured among the carpal bones. So that tenderness is actually due to the fracture of scaphoid here. Most commonly fractured. Fine. Next one. The tingling and painful sensation in the lateral region of the thigh may occur in the older and overweight individual as a result of bulging abdomen. Okay, elderly people, bulging abdomen, compressing a nerve beneath the inguinal ligament. What else do you need, man? What else do you need? See, this is the good thing about the clinical question. In what will happen, examiner will try to explain you, and while explaining, he is like giving away everything to you. I hope you remember there will be ASIS, anterior superior iliac spine, and then you'll be having the pubic tubercle. Between them there will be a ligament. That ligament is inguinal ligament. And here you just imagine this is like your thigh. Then I have explained you it very clearly from L2 and L3. There is one nerve coming, and that nerve, all the words are given in the exam. All the words are given in the question there, guys. Yes. So in older, overweight individual, bulging abdomen, that nerve is actually getting compressed beneath the inguinal ligament. That is your lateral cutaneous nerve of thigh. Lateral cutaneous nerve of the thigh. And if this is getting compressed over here, then what will happen? Tingling and painful sensation on the lateral side of the thigh. So lateral side of the thigh, there will be tingling and painful sensation. I hope all of you remember this we have learned. Yes, Meralgia Paresthetica. Okay? Yes, absolutely correct, Dr. Komala. Meralgia Paresthetica. Yes, it is involving which one? Anterior femoral cutaneous? No. Femoral branch of genitofemoral? No way. Ilioinguinal? No way. Yes, it is the lateral femoral cutaneous nerve, guys. Absolutely correct. And my diagram says it all. Welcome to my anatomy classes. I will teach you diagrammatically in a very conceptual manner, guys. Okay, in diagrams itself, you can easily learn that. No need to mug up at all. Fracture of surgical neck of the humerus results in. See, whenever you see humerus bone there, suppose if this is your humerus over here, and near the surgical neck of the humerus, or we can say behind the surgical neck of the humerus, there is a nerve passing, and that nerve will be axillary nerve, guys. Axillary nerve passes behind the surgical neck of the humerus, and it is going and supplying to two muscles. One will be the deltoid muscle, another one will be the teres minor muscle, guys. Deltoid muscle and teres minor. And deltoid muscle is the one which is giving this beautiful rounded shape to your shoulder here. So your shoulder appearing rounded here because of which muscle? Deltoid muscle. Now let us see, if that is injured, then what is going to happen? Loss of sensation in dorsal of forearm? No way. Flat shoulder? Yes, of course. A rounded contour of the shoulder is due to which muscle? Deltoid muscle. But if that muscle is paralyzed, that is gone. Flat shoulder. Wrist drop? No. Wrist drop is due to radial nerve injury. Claw hand? No. Claw hand will be actually due to the ulnar nerve and median nerve injury. No way related to your axillary nerve. So it should be flat shoulder. Next one. When median nerve is paralyzed in carpal tunnel, which of the following occurs? Median nerve is injured in the carpal tunnel. See, first of all, try to recall in your mind. In your hand, you're having like 20 muscles in the hand, and out of the 20 muscles, 15 muscles are supplied by ulnar nerve coming from here, and then median nerve will be supplied to the remaining 5 muscles. So which 5 muscles the median nerve is supplying? It is supplying to thenar, three thenar muscles, and then lumbrical number 1 and 2. So let me just recall and write down here. Median nerve will be supplying to your thenar muscles, but which only 3 thenars? Number 1, it will be supplying to flexor pollicis brevis, and then abductor pollicis brevis, and then it is also supplying to the opponens pollicis, not adductor. Adductor pollicis is supplied by? Adductor pollicis will be supplied by what, sir? Ulnar nerve. And then lumbrical number 1 and the lumbrical number 2. Chalo. Now let us, after recalling all these things, let us now see here, sir. When median nerve is paralyzed in the carpal tunnel, which of the following occurs? Abductor pollicis will be paralyzed. Yes. Flexor pollicis longus? No. Flexor pollicis longus will be supplied in forearm. And injury here is in carpal tunnel. No problem with that one. Flexor pollicis brevis. See, remember, flexor pollicis brevis is a part of thenar, but this will be supplied by median nerve as well as it is also supplied by ulnar nerve. It will be having like heads, 2 heads. It is also supplied by ulnar nerve. So if median nerve is injured, it doesn't mean that it is completely paralyzed. Ulnar nerve is also supplying to that one. That's an exception. That is the reason why I have given you this question there. Okay. So if only median nerve is paralyzed, doesn't mean that even flexor pollicis brevis is completely paralyzed. It is also supplied by ulnar nerve. Loss of sensation of thenar eminence? No. See, we have learned in our DocTutorials app, we have learned that medial 1.5 digit skin will be supplied by ulnar nerve. Lateral 3.5 digit skin will be supplied by median nerve. Fine. But in that, I told you very clearly, the lateral 3.5, again I explained you in detail. In that lateral 3.5 also, the 3.5 digits is supplied by digital branch, whereas the 3.5 palm will be supplied by palmar cutaneous branch. Actually, this will not be done in the FMG. So this is something additional that will be doing in the NEET page. Okay, now because here it is required. Here the clarity is required. The 3.5 digits will be supplied by digital branch, whereas 3.5, palm, the skin covering here will be supplied by palmar, and that palmar cutaneous branch is given superficial to flexor retinaculum. If you will remember, median nerve is coming beneath the flexor retinaculum. Okay, let me draw it here. For example, if this is your flexor retinaculum, median nerve will be coming beneath the flexor retinaculum through the carpal tunnel. This is your median nerve. But median nerve will give a branch, palmar cutaneous branch, that is coming superficial to that one. I hope you are getting me. So that is the reason why loss of sensation of thenar eminence will also not be there. Why? Because in our question here, the nerve is paralyzed in carpal tunnel. Yahan par. So therefore, the palmar cutaneous branch is actually spared. It is still, you will be able to sense here, but not the digits, sir. Wow, what a clarity here. Understanding my point here. So Understanding my point here, guys? So in this question, wantedly I have given you the options very closely so that you get to know what is the clarity like in them. Otherwise, the students will be like, "Acha, everything is involved in the median nerve, na, sir. Why these options like this here?" So I've given the options very closely there. I hope you got this very clearly, guys. Next one. In the obstruction of second part of the axillary artery, the anastomosis between the following artery will maintain the blood supply of the upper limb. Oh, scapular anastomosis. I hope you remember our big diagram. Beautiful one. So if the second part of the axillary artery is obstructed, the anastomosis will be between the subclavian artery and the axillary artery. The subclavian artery, first part of subclavian artery and the third part of the axillary artery, guys. So deep branch of transverse cervical artery and subscapular artery. Yes, they are forming anastomosis here. Anterior and posterior circumflex humeral artery, they are not at all involved in the anastomosis. Okay, those two are branches of third part of the axillary artery. They are not involved in the anastomosis itself. Posterior circumflex humeral artery and then circumflex scapular artery, no way connected here. And then suprascapular artery and anterior circumflex humeral artery. So you can easily rule out all the options here, guys. And yes, my dear friends, you can easily rule out them. And yes, my dear friends, you can easily try to recall these options here, sir. Okay, so you can see like during my classes, guys, during my classes, you have seen in the videos and all. So I have drawn like very clear diagram, guys, regarding the scapular anastomosis. Understanding? Following a deep cut overlying the hypothenar eminence, following a deep cut overlying the hypothenar eminence, it is observed that patient cannot hold a sheet of paper between second and third digits. Which of the following nerve is most likely damaged? Come on. If I give a sheet of paper in between the digits, that is nothing but I'm doing what? I'm doing adduction. And remember, my dear doctors, adduction is done by palmar interosseae. Pad and dab. I hope you remember that one. Pad and dab. Yes, the pad and dab. Palmar interosseae will be helping in adduction of the fingers. And yes, the moment you listen the word as interosseae muscles, they will be supplied to which nerve, sir? Ulnar nerve. The moment you listen the word as interosseous muscle, they'll be supplied to what, sir? Ulnar nerve. Yes, it has to be supplied by the deep branch of ulnar nerve. Very good, Dr. Kanika. Card test जो हम करते हैं. Very good. Dr. Yogesh Kumar is asking, sir, FMG के लिए भी please rapid revision का session ले लीजिए. Yeah, sure. We'll consider Dr. Yogesh. Yes, we'll do it. Of course, DG26. क्या ये वीडियो लाइव है क्या? हाँ जी. मैं यहाँ पर आपके नाम देख रहा हूँ, आपको जवाब भी दे रहा हूँ. I am actually seeing all your chats here. Okay. So I am seeing all your chats here, whatever your responses you are sending me here. So it's absolutely live. Yes, Dr. DG, I'm taking a live here. Yeah, it's live. A person had injury to right upper limb. He is not able to extend fingers, but able to extend the wrist and elbow. Oh, read it very carefully. The person is not able to extend the fingers को वो extend नहीं कर पा रहा है. Oh, but he is able to extend the wrist. Okay, so if he is not able to extend the fingers, it means extensor digitorum muscle is gone. Simple. Make it very simple, sir. He is not able to extend the digits. Extensor digitorum muscle is gone. Extensor digitorum muscle belongs to which compartment? Posterior compartment. And that muscles are supplied by PIN, posterior interosseous nerve. Posterior interosseous nerve is injured here, which is a branch of radial nerve. And just to tempt you people, first option is given as radial nerve. No. Why? Because radial nerve is not injured here. Why? Because explanation is given clearly. You are able to extend the wrist. So if you are able to extend the wrist, all that remaining extensor, carpi, radialis, longus, ECRL, all of them are working very well. Radial nerve is good. It is supplied to ECRL and all. But posterior interosseous nerve is gone there. Yes. A 10-year-old boy taken for venesection of great saphenous vein. I hope you remember great saphenous vein forming from the foot and all. Vein developed sudden pain and paresthesia on the medial aspect of the great toe. And we know very well, medial side of the great toe, just now I told you, it is supplied to which nerve? Saphenous nerve. So which nerve is involved here? Which nerve is injured here? On the medial side, saphenous nerve, which is a branch of femoral nerve. Always remember towards the medial side it is saphenous nerve, which is a branch of femoral nerve, and on the lateral side of the foot it will be by sural nerve, and sural nerve is a branch of which one, sir? The tibial nerve. The skin on the medial side of the foot, saphenous. The skin on the lateral side of the foot is by sural nerve, sir. A young patient presented with the loss of sensation in the sole of the foot, plantar region. And I hope you all know very well our golden rule. Try to recall from our videos. If this is the foot here, plantar region, what is the nerve coming from behind? Tibial nerve. And tibial nerve will be dividing into medial plantar and lateral plantar. 1.5 and 3.5. You remember that one? So plantar surface is supplied by which nerve? Plantar nerves. Tibial nerves is not. With paralysis of the medial side of the plantar muscles of the foot, most likely nerve involved is, of course, it will be tibial nerve. Tibial nerve is giving the medial plantar and the lateral plantar nerve. A 37-year-old man suffers a traumatic injury to the axilla. That damages the thoracodorsal nerve. Going and supplying to which muscle? Latissimus dorsi muscle. Thoracodorsal nerve will be supplying to latissimus dorsi muscle. Which of the following movements of the arm or the scapula could be affected in the patient? Oh. So my dear doctors, remember latissimus dorsi पता है आपको? Latissimus dorsi जिसको हम बड़े प्यार से lats कहते हैं. Latissimus dorsi muscle. It is supplied by thoracodorsal nerve. Okay. Actually, on DocTutorial platform, I am also going to make certain videos wherein you can learn the actions of the muscle in a very funny way. Guys. Okay, now. So remember, latissimus dorsi muscle will be actually used for scratching of your opposite side as scapula. So just try to recall in your mind, scratching the opposite side scapula. Okay. So remember, in that, what are you doing? You are actually doing adduction. So latissimus dorsi muscle will be helping in adduction of the arm, and even the medial rotation as well as extension of the arm, sir. Okay. So scratching of the scapula of the opposite side like that. Okay, now. So adduction as well as medial rotation and then extension of the arm. So एक बार लिख देता हूँ मैं. It will be actually helping in adduction and medial rotation and then extension of the arm. So this is the function of your latissimus dorsi. Okay, adduction can be affected, guys. Abduction has nothing to do with that one. Flexion nahi, it is actually extension. It is not lateral rotation, it is actually medial rotation, sir. So which movement of the arm can be affected here? That is the adduction can be affected here. So good. In a subclavian artery block at the outer border of first rib, which of the following arteries help in maintaining the circulation to upper lip, sir? All of the following arteries will help in maintaining the circulation to upper limb except one, sir. Subscapular artery is involved in scapular anastomosis. Yes. Thyrocervical trunk is also involved. Yes. Suprascapular artery is also involved, but not superior thoracic artery. Superior thoracic artery, if you all remember, it is the first branch of axillary artery. Axillary artery, first part branch. Axillary artery is divided into how many parts, sir? 3 parts. By pectoralis minor muscle. There will be pectoralis minor muscle here, the first part, the second part and the third part here. So first part will actually give a branch, and that branch will be the superior thoracic artery, and superior thoracic artery has no role in the scapular anastomosis. Is it okay? Done. Simple squamous cells are lining. Oh, I can straightforward see the options cornea, tonsil, pleura, vagina. In all of that, you can clearly mark the answer as pleura there, sir. Why? Because whether it is pleura covering the lung, pericardium or peritoneum, all of them will be lined by a simple squamous epithelium known as mesothelium. Simple squamous epithelium. Okay, simple squamous. Flattened cells, only one layer. But whereas remaining whatever options are given, there you have squamous only, but that will be stratified. Multiple layers will be there. And don't try to mug up the epithelium. You just go and watch my video. There I have told you very conceptually. In whichever region in our body there is wear and tear, where there is, there you require multiple layers. Stratified squamous epithelium is required. So of course in cornea, tonsils, vagina, stratified squamous. Pleura will be having a simple squamous. Which type of collagen is present in the skin? It's a straightforward question. Every student will be learning this many a times. It is type 1 collagen in the skin, sir. Okay. So let's not spend much time here, which are like direct one-liners. And like few questions I have given like that, where you can easily able to answer, sir, like just to balance the paper. All of the following are examples of traction epiphysis except See, students will be always getting confused between two types of epiphysis. One is the pressure epiphysis, another one is the traction epiphysis. I will tell you, welcome to my anatomy class, sir. I will tell you one golden rule here, only one word you remember. Pressure epiphysis, it is that end of the bone which is involved in joint. It is articular. Whereas traction epiphysis is that part of the bone which is non-articular, not involved in the joint. Epiphysis, make it simple. Epiphysis means ends of the bone. Diaphysis is the shaft of the bone. Epiphysis is end, but in the end also, some parts will be involved in the joint, articular, and some parts are not involved in the joint, non-articular. Just by that, you can easily identify here. Come on. Mastoid process. And one more thing, the name itself is telling you. Traction epiphysis, it is formed due to traction. Tendon will be inserting on that one, and due to the pull of the muscle, traction of the muscle, that epiphysis is formed. Whereas pressure epiphysis, because it is weight bearing, pressure bearing, weight bearing, it is involved in the joint there. Is it okay? Chalo. Just keep these 2 points in mind. No need to, mug up or ratta all these examples here, sir. Ratta maane ka zarurat hi nahi, sir. No need to mug up. Mastoid process here, formed due to traction. Yes, sir. This is traction epiphysis example. Tubercles of humerus. The tubercles of humerus, less greater tubercle, lesser tubercle and all. Yes, they are also formed due to the traction epiphysis, pull of the muscle. And you remember, greater tubercle, lesser tubercle, they are non-articular. They are not involved in the joint here, sir. They are not belonging to the joint there. Trochanter of femur, that is also traction, formed due to pull. Whereas condyles of tibia, are actually involved in the joint, articular. So that is an example of pressure epiphysis. Now it has become like easy time pass for us. So please don't follow your first year MBBS method, writing the epiphysis, writing the types and mugging up. Concept. Anatomy is very much conceptual. Concept is important, guys. So whichever is articular, involved in joint, pressure, weight bearing. Which is non-articular, not involved in the joint, it is formed by traction, pull of the muscle. That is traction epiphysis, guys. Okay? And there will be one more very much important for your exam, atavistic also. I'll tell you later on wherever it comes, guys. The type of joint between the sacrum and the coccyx. This is like, takeaway question. Sacrum and coccyx in the midline. That word should come in your mind. And all the midline joints here will be the examples of secondary cartilaginous joint. That is symphysis. Mandibulosternal joint, xiphisternal joint, intervertebral disc, pubic symphysis, between the sacrum and everything in the midline will be the examples of secondary cartilaginous joint. But please remember, for your NEET PG, except it is in midline but not secondary cartilaginous. That is symphysis menti. Except that one, all the midline joints here will be the examples of secondary cartilaginous joints. Stratified squamous epithelium is seen at all of the following sites except stratified squamous, multiple layers, stratified, everywhere where there is wear and tear. Skin, yes. Vagina, yes. Esophagus, yes, you are eating the food and all, so there is wear and tear there, but not gallbladder. In gallbladder, you don't have stratified squamous, there will be columnar epithelium, simple columnar epithelium. Concept, I'm telling you. I'm trying to tell you the concept here. Don't mug up the examples, guys. Sphenoid and vomer joint is of which type? See, the moment I look at the name, sphenoid bone and the vomer bone, as a simple medical student, what should strike in my mind? Sphenoid and vomer, yes, they are actually your bones belonging to your cranium. And between the cranial bones, which type of joint do you have, sir? Sutures. Between the cranial bones, which joint do you have? Like your sutures will be there. But my dear friends, remember, this sphenoid and vomer is a special category. No. Hold on. It is not D. It is actually a special category between the rostrum of the sphenoid and the vomer here. It is going to come and fit this. The rostrum of the sphenoid will come and fit in the vomer, and that is a special type of suture and is given a separate name. It is known as shindylisis. Guys. Okay. So that is one example separately that you have to remember. Yes, that is shindylisis. Is it okay, Dr. Chirag? Lovely. Lymphatic drainage of glans penis or clitoris will be by the inguinal lymph nodes, but remember the deep inguinal lymph nodes. I hope you people have heard about those lymph nodes of Cloquet and Rosenmuller. Lymph nodes of Cloquet or Rosenmuller. Yeah, those, the deep group of inguinal lymph nodes, they are the one which are going to drain the lymph from the glans penis and the clitoris of the females. Example of traction epiphysis. Come on, guys. I would love to, if you people are able to answer this one, guys. Just now I told you the concept. So traction epiphysis. Come on. Trochanter of femur. Yes, sir. It is formed by the pull, and it is non-articular. It is traction. Okay. Os trigonum and coracoid process. These two are the classical examples of atavistic epiphysis. Atavistic epiphysis. And what is the meaning of atavistic epiphysis? Previously, this used to be a separate bone, but during the development, it is fused along with the bone. Best way, remember, coracoid process. It is now a part of your scapula. The moment I say coracoid process, what is striking in your mind, sir? It is a part of your which bone? Scapula. But previously, that used to be a separate bone. Okay, and now it is fused with that. So that kind of end is known as atavistic. So that is why I've given you this question, so that you can just revise this. Actually, what will happen, we are having like so many big concepts and all those things, and all 19 subjects to be learned and revised for your NEET PG exam. So in that, what will happen, most of the students will forget about these simple topics, but they are testing on that one. Joints, definitely a question will come. Epithelium, they'll be giving a question always. And nowadays to a NEET PG exam, they were giving like image based question for epithelium. Exactly. So that is the reason why what I have done is, even though if you are seeing, if you are observing my discussion here on our DocTutorials platform right now, in the beginning, yes, I have given you all the clinical questions, integrating with other subjects and all those things. But in the middle, I have slipped in these silly questions also. Silly in the sense like simple ones. Especially where the students will tend to make a mistake, like shindialysis, what are the example to be remembered? Atavistic epiphysis, in the options I have given you here, these two examples you have to remember, sir. Os trigonum and coracoid process. So that is the reason why I have slipped in these questions in the middle, so that even though, yes, I agree, you have to learn all the concepts, all the subjects and all. So somewhere in the middle, you should strike in your mind, yaar, joints and epiphysis वगैरह पढ़ना ज़रूरी है. Joints, epiphysis, epithelium, very much important for your exams. Okay. Yes, very good, Dr. Roy. Identify the marked muscle in the diagram. Yes, you can easily identify this marked muscle here. That is a tendon which is actually going to your great toe. Great toe is known as hallucis, and it is coming from which compartment? Anterior. Anterior compartment will be having extensor muscle. Extensor hallucis longus. It's an extensor hallucis longus, guys. Simple. Chalo, आगे बढ़ते हैं, sir. Okay. Now, which of the following structure doesn't develop in the mesentery of the stomach? Okay, liver develops in the ventral mesentery. Okay, spleen develops in the dorsal mesentery, and the pancreas will also develop in the mesentery, like ventral pancreatic bud and dorsal pancreatic bud, they'll fuse to form, but not the kidney. Yes, absolutely correct. I'm really happy, Dr. Chirag, Dr. Ankit, Muskan, Pritiraj, Kamal. Absolutely correct. Kidney is not developing in mesentery, it's retroperitoneal. The cecum is found to be placed below the epigastrium, just below the stomach, in the midline. Which of the following abnormality must have taken place while rotation of gut? Is it malrotation, non-rotation, reverse rotation, or mixed rotation? So I'll tell you one thing. I hope you have learned about the rotation of midgut. Foregut will actually rotate 90 degrees in clockwise. Midgut will rotate like 270 degrees in anti-clockwise, and hindgut, it will not rotate. Now, when you learn about the midgut rotation, yes, I have explained it very clearly. There will be three of them: 90 degrees, 90 degrees, and 90 degrees. First 90 degrees anti-clockwise, then second 90 degrees, and third 90 degrees anti-clockwise. Okay, 270. But now, what is going to happen? Only the first 90 degrees will occur, and the second 90 degrees will occur. So, what is going to happen? Only the cecum will come in the midline. And in the third 90 degrees rotation, what is going to happen? The cecum will go from the epigastric region. It will be actually going subhepatic region. It will be going down into the actual location of the cecum in the iliac fossa. Okay, so if that third 90 degrees will not occur, then what is going to happen? It will stop here only. The midline cecum is a characteristic feature of which type of rotation, sir? That is your mixed rotation. You can see the diagram here. This is like non-rotation only, sir. Only first 90 degrees will occur. Small intestine entirely on one side here, large intestine entirely on the other side, size. Okay. And yes, midline cecum, 290 degrees rotation has already occurred. The third one will not occur. Here is the mixed rotation. Okay. And reverse rotation is only first 90 degrees will occur. Remaining 290 degrees will actually occur in the clockwise direction. It should normally in the anti-clockwise direction, but it is reversed in clockwise direction. So you can see small intestine in front of the large intestine. That is how you are going to identify this one. Okay. Yes, get set ready. If FMG students are listening to this class, get set ready. In the FMG classes, we'll be actually studying only about the rotation and angle. That's all. Okay, 90 degrees clockwise, 270 degrees anti-clockwise. That's all. We'll study that one. Yes, when you come to the PG classes, welcome to my PG classes at DocTutorials platform. At that time, I'll tell you about all these abnormalities also and how to identify that one. Okay. Next one, guys. At birth, an infant presents with a stomach that has herniated into the diaphragm. Stomach herniated into the diaphragm. Where is the defect? So it is telling clearly about what, sir? Congenital diaphragmatic hernia. And congenital diaphragmatic hernia is due to the absence of pleuroperitoneal membrane. Pleuroperitoneal membrane. Muscle attached to the arrow-marked region in the given image. In the given image, this arrow-marked region here is actually the lesser trochanter. And lesser trochanter, two muscles are getting attached. One is iliacus, another one will be the psoas major. Iliacus and psoas major. Okay, I think it's like very high time. Already we started the discussion at 7 o'clock, but it is the questions from all the three tests. I understand. I think some people are getting impatient over there, but still, let us just finish it faster, a little bit faster. A 38-year-old woman with a history of heartburn suddenly experiences excruciating pain in the epigastric region of the abdomen. Okay. Surgery is performed immediately upon admission to the emergency room. There is evidence of ruptured ulcer. Oh, posterior wall of the stomach. Evidence of a ruptured ulcer in the posterior wall of the stomach. Where will the surgeon first find the stomach contents? Posterior wall of the stomach or behind the stomach. Obviously, you'll be having the lesser sac. And lesser sac, what is another name of that one? Yes, that is omental bursa. Omental bursa is nothing but lesser sac. So when the surgeon is actually trying to see the contents of the stomach will be first seen in which one, sir? The lesser sac or the omental bursa. Is it okay? Fine here, my dear friends. And you can see like I have explained it very clearly in one of the videos about the rotation of gut. The foregut will rotate 90 degrees, and after rotation of that it will result in the formation of greater sac and the lesser sac, and lesser sac will be lying behind the stomach, and all the contents will be seen over there, guys. Mullerian duct anomaly may include the absence of any of the following, except, see, Mullerian duct we all know very well. It is going to form the female genitalia. We have learned it very nicely. Wolffian duct. From the name itself you can understand. Wolffian. Manly. It is going to form the male genitalia. On the other side, Mullerian duct. And Mullerian duct is going to form the female genitalia. From the name itself you can understand that one. है ना? जैसे मैं कहता हूँ हिंदी में नाम में ही तासीर है. उसके नाम से ही समझ सकते हो. है ना? Wolffian male and the Mullerian female genitalia. And now in female genitalia, it is going to form what? It is going to form the uterus, yes, the upper part of vagina, and yes, even the fallopian tubes, the uterine tubes, but not ovaries. And remember, ovaries are actually formed from the genital ridge. Gonads are formed from the genital ridge. The male gonads and the female gonads, okay, are formed from the genital ridge, not from the Mullerian duct and Wolffian duct. Genital tubercle will actually give rise to glans penis in male, and homologous to that one will be the clitoris. So genital tubercle will be actually going to form the clitoris. Yes, guys. So therefore, I want you to be like very much careful with these words here, sir. Genital ridge, genital tubercle, genital swelling, genital fold. These four words will be confusing the students a lot. Genital ridge, genital fold, genital tubercle, swelling. Okay, so tubercle will actually give rise to glans penis in the male, which is homologous to clitoris in the females. A patient with external hemorrhoids develops pain while passing stools. The nerve mediating this pain is external hemorrhoids. Okay, and that nerve has to be definitely pudendal nerve. Why? Because external hemorrhoids beneath that pectinate line. I hope you remember, above the pectinate line and beneath the pectinate line. Okay now? Okay na? Is it okay? So therefore, my dear friends, remember what is the nerve involved there? That is your pudendal nerve, sir. Now, a posteriorly perforating ulcer in the pyloric antrum of the stomach is most likely to produce initial localized peritonitis or abscess formation in the following. I think I told you the same thing, but here the wordings are changed here, sir. There it was like a clinical question, surgeon trying to see that or contents will be seen here. And yes, it is nothing but the same thing, omental bursa or the lesser sac. While exposing the kidney from behind, all of the following nerves are liable to injury except what, sir? Okay, now for example, if you remember my diagram, if this is your kidney and we are seeing from behind, हम पीछे से देख रहे हैं, posterior view. When you see posterior view, my dear doctors, upper part of the kidney will be related to what? Diaphragm. Whereas the lower part of the kidney will be related to three muscles. On the medial side, you'll be having psoas major muscle, and then there will be quadratus lumborum muscle, and then there will be transversus abdominis. Now we are not going into the detail of that. How come all those things? Yes, they are the one which are going to form your posterior abdominal wall. है ना? Posterior abdominal wall, fine. The psoas major, quadratus lumborum, and transversus abdominis. And now, my dear doctors, about the nerves. Between the psoas major and quadratus lumborum, you'll be able to appreciate two nerves here, the iliohypogastric nerve and the ilioinguinal nerve. Iliohypogastric nerve and ilioinguinal nerve coming from L1. Okay. So, ilioinguinal nerve, yes. Iliohypogastric nerve, yes. They are liable to injury. And I hope my students remember that behind the kidney, you will be also able to appreciate the rib here. That is your 12th rib. Okay. And beneath that 12th rib, you'll be able to find the subcostal nerve, artery and vein. So yes, even the subcostal, below the rib, subcostal nerve is also liable to injury. Is it okay? But not the lateral cutaneous nerve of the thigh. No way. Lateral cutaneous nerve of the thigh I studied separately in the previous questions. Somewhere we have learned about that. Meralgia Paresthetica मैंने आपको पढ़ाया था. Try to recall from there. Is it okay? So when you learn about the posterior surface relations of kidney, these three nerves are liable to injury. Now, why did I give this question in our LI test series? Why? Because in the recent exams of NEET PG and all, yes, relations of the kidney extremely important, sir. Anti relations and the post relations, and recently there was an image based question about the anti relation also. Okay, so that's why what I have done is that I have given you one question regarding the relation that was a little bit clinical. So when you're trying to expose the kidney from behind, which nerves are liable to injury? These are the nerves which are liable to injury, sir. Next one. In portal hypertension, lower end of the esophagus may show dilatation of the veins. Which of the following vein drains into the portal vein from the lower end of the esophagus? Okay, this one is your esophagus here, and this one will be the stomach here, my dear friends. You all know very well what is this vein here. There will be the left gastric vein, and yes, from the esophageal, lower end of the esophageal veins. And whether it is right gastric vein or left gastric vein, both of them are going to drain the blood finally into which one? The portal vein. They are the tributaries of portal veins. Gastric veins, the right gastric and left gastric veins are tributaries of which one? Portal vein. I am telling vein, not the artery. Okay. So, which of the following veins will be draining from the lower end of the esophagus? Yes, it should be definitely the left gastric vein, sir. Yes. Loading doctor, Pretiraj. Absolutely, absolutely. ठीक है ना? Shlok is asking, is it useful for FMG? Of course, Shlok, it will be useful for FMG, NEET, PG or whatever exam you are preparing for. Definitely it will be helpful. Concepts will be the same. It will never change. It will definitely help you. The following, the mesentery of the small intestine along its attachment to the posterior abdominal wall crosses all of the following structure except. See, I hope already you know about this one, the mesentery of the abdomen here, sir. So this is the mesentery here. Okay, that is the mesentery. Fine. And now that mesentery is going to cross. See, you can clearly see the mesentery is towards the right side. So it is going to cross the third part of the duodenum. It is also crossing the aorta here, and then the inferior vena cava here. That means it is crossing the structures towards what, sir? The right side, not the left one. It is going to cross the right ureter there, the right gonadal. So the mesentery is going to cross all the structures towards the right side. Yes, third part of the duodenum, aorta and the right ureter, not the left one. Left possible ही नहीं है. So if you just know the basic thing about the mesentery will be, root of the mesentery will be towards the right side. You can easily answer this one. It cannot cross the structures towards the left side, sir. Simple concept. Okay. Next one. The blood supply of the ventral 2/3 of the interventricular septum of the heart. Hello, my dear doctors. Do you all remember my diagram? Do you all remember my diagram? Come on. Right ventricle, left ventricle. Kya kiya jaye? What to do? I told very clearly in our videos. Come on. Interventricular septum. Right ventricle, left ventricle. Interventricular septum. And just mark an imaginary line in the middle. Everything towards the right side is taken care by right coronary artery. Everything towards this side is taken care by left coronary artery. Now what is given in the question? Ventral 2/3 of interventricular septum, anterior part, ventral part. So interventricular septum, ventral part is supplied by which coronary artery? Left coronary artery, guys. It is supplied by left coronary artery. So this ventral 2/3 of interventricular septum is supplied by left coronary artery. That is why I told you very clearly during the classes also. I told you very clearly, guys. Okay. You cannot mug up this one, the ventral, dorsal, 2/3, 1/3 and all those things. My diagram will actually help you. This diagram should come in your mind. When this kind of questions will come, this diagram should come in your mind, sir. Okay, next one. The nerve involved in the given condition passes through. Given condition, lurching gait. Trendelenburg sign. Everyone knows it is superior gluteal nerve is involved. Fine. But is passing through which foramen? Greater sciatic foramen, that too above the piriformis. If you remember the greater sciatic foramen, what is the structure passing through the greater sciatic foramen, sir? Piriformis muscle, and there are some structures above the piriformis and below. So above, superior. So above the piriformis through the greater sciatic foramen, sir. Which of the following statement is incorrect concerning the process of spermatogenesis? So regarding spermatogenesis, primordial germ cells originate from embryonic mesoderm. Absolutely wrong. The primordial germ cells are coming from epiblast, not from mesoderm. Primordial germ cells arrive in the future testis region at the week 5, correct? And remain dormant until puberty. Absolutely correct statement. 512 spermatids are formed from single spermatogonium. You remember spermatogenesis? Yes. Spermatogenesis begins with what, sir? Spermatogonium cells. Okay, now. And remember, from the single spermatogonium, how many spermatozoa are going to form, sir? 512. Absolutely correct. And then the primary spermatocyte undergoes meiosis to produce haploid secondary spermatocyte. Absolutely correct. Number of chromosomes are reduced to half from the primary spermatocyte to secondary spermatocyte. Meiosis 1. So those three statements are correct. The first statement is wrong, sir. So which of the statement is incorrect? The first one is incorrect, sir. Okay, now. In a female child at birth, oocyte progress 2. At birth, the oocyte will be arrested in which phase only, sir? It will be in prophase of meiosis 1. Yes, I hope you all remember, before the birth itself, during intrauterine life, the oogenesis will be actually arrested during the prophase of meiosis 1, sir. Meiosis 1 prophase. Okay. Next one. Dr. Arif is actually telling, sir, full anatomy hi padha do, acha hota. I would love to help my students to any extent possible. Yeah. At birth, umbilical cord normally has, umbilical cord will actually have 2 arteries. Both the arteries will be there, but vein will be only one. Okay, now. So one umbilical vein will be there, but both the arteries will be there, sir. Which one? One umbilical vein and 2 umbilical arteries will be there. Which umbilical vein do you have, sir? Only the left umbilical vein will be present. I hope you remember that very famous mnemonic. Yes, right will regress. Right will regress. Left is left, sir. So which umbilical vein is left right now, sir? Yes, left umbilical vein is left, sir. From which of the following does nucleus pulposus is formed, sir? I think you all remember nucleus pulposus is the remnant of notochord. ये तो आप सबको पता ही होगा. Nucleus pulposus is actually the remnant of, yes, notochord. So we have to just identify which is notochord from here. What is this A here, sir? This is actually the neural tube, the actual neural tube, which is going to form your central nervous system, brain and spinal cord. And what is B here? Just aside, on the sides of the neural tube, we'll be having the mesoderm, intraembryonic mesoderm, which is divided into three parts, sir. Paraxial, intermediate, lateral plate. So this one will be the paraaxial mesoderm. And D will be actually the intermediate mesoderm, and whereas C is actually the notochord. And what is the remnant of notochord? Nucleus pulposus. So answer should be C. Good. Left superior intercostal vein drains into. It was a direct question once asked in your INSET exam also. Remember, on the right side, the right superior intercostal vein drains into azygos, but whereas the left side, left intercostal vein drains into the left brachiocephalic vein, sir. Yeah, exactly, Dr. Roy. Absolutely correct, Dr. Roy. Left brachiocephalic vein, sir. Okay. Ejaculatory duct is derived from. Ejaculatory duct in males will be derived from the Wolffian duct. Another name of the Wolffian duct will be the mesonephric duct, sir. Okay, so it's a straightforward question. I hope you all remember the derivatives of mesonephric duct or Wolffian duct, sir. People love to remember all the derivatives with the mnemonic as SEED. Seminal vesicles, ejaculatory duct, epididymis, and then ductus deferens. So these are all the derivatives of your Wolffian duct, sir. What is the action of the muscle at hip joint attached to the aromarked region? This is something beautiful here. Aromarked region here is actually the tuberosity. This one will be the gluteal tuberosity. Aromarked muscle is gluteal tuberosity, and here the muscle attached with the will be the gluteus maximus muscle. And now the interesting thing here is that every student knows only that gluteus maximus is helping in extension at the hip joint. Extension at the hip joint, sir. ठीक है ना? Extension सबको पता है. Fine. Now in the exam the option given is two options there. Option number C and D here. Extension is given. अब आगे नहीं पता. How to mark the answer now, sir? Okay. I have actually taken a screenshot from 42nd edition of Gray's Anatomy, the latest edition of the Gray's Anatomy. In that, it is clearly mentioning that gluteus maximus, function number 1, it can extend the flexed thigh. For example, you are sitting there, I am sitting here. Observe, listen this very carefully, sir. There is something interesting here. You are sitting there, I am sitting here. Our thigh or our hip region here, it is flexed. Now, from the sitting position, if you stand up, extension at the hip joint. Number 1 function. Every student will be knowing only this one function here. But apart from that, if you read the entire thing from the 42nd edition of Gray's Anatomy, my dear doctors, remember, hello, it is intermittently active in the walking cycle in climbing stairs. It is intermittently active in walking cycle and in climbing stairs, and continuously active in lateral rotation of the thigh. Okay, continuously active in lateral rotation of the thigh. Upper fibers are active in powerful abduction of thigh. Upper fibers. Oh my God. The gluteus maximus is helping in extension as well as lateral rotation as well as abduction. Extension, lateral rotation as well as abduction. So come back here. You know extension very well. Remember, it is helping in, yes, lateral rotation as well as abduction. Option number C here. Okay, and yes, it is actually a screenshot straight away from the Gray's Anatomy 42nd edition, guys, for your reference. Okay, and you can read the entire paragraph later on if you want any time. I'll forward that screenshot to you, sir. Chali, next one. The last and final question here, guys. The given congenital anomaly is due to the defect in, and you can very clearly see in this one that the structures from the abdomen are actually herniating here. and that is nothing but congenital diaphragmatic hernia, and congenital diaphragmatic hernia is due to the absence of pleuroperitoneal membrane. Congenital diaphragmatic hernia yes, congenital diaphragmatic hernia is actually due to the absence of pleuroperitoneal membrane. Is it okay, my dear friends? Okay, so that is all about all the questions which were given in the elite test series of anatomy at DocTutorial. I hope you have attended the test also, and now this was a discussion, guys. Yes, I think it is a little bit extended, but I think it is worth discussing all these concepts. So whoever have learned all these concepts, they are actually revised in your mind very well, nicely. But whoever are listening for the first time, you can go through the video again and revise it again, guys. Is it okay? And my dear friends, I would request you to attend all the test series. Entire schedule is given for all the subjects, and tomorrow we are having the biochemistry elite test series. It will be live. The test will be live from 7 p.m. onwards. You will get all the details or in the app. So give the test series, and yes, of course, my dear friends, you have seen how I have actually framed all the questions over there, like clinical questions related with the other subjects and all those things, because learning in the class is totally a different art, whereas solving the questions is totally a different art. When you see that question and 4 options in front of you, the mind starts working in a different manner. Is it okay? So try to solve those questions here. I hope this session was useful to you. I was of little bit help to you guys. Okay, so thank you all, and you are like really interactive people here. So Dr. Chirag, Dr. Preeti, Kamlesh, Dr. Preeti, Ankit, Kumbala, Dr. Roy, Sushmita, Muskan. Thank you all, guys. God bless you all. God bless you all with lots and lots of success. Yes, and do attend the test in the later series. Okay, so thank you. Take care. Goodbye. God bless you.